It just felt like I was broken, something was wrong, and I was right, something is wrong.
First, it's not like I get to go back, right? A lot of people get to go back because of lipedema. I don't necessarily get to.
It was one of those moments of, I'm not crazy. I knew like my body wasn't reacting.
I want to take you all on a journey with me. During quarantine in 2020, like a lot of people, I gained a bunch of weight. So a couple years ago, I decided to take my health a little more seriously, and I lost about 60 pounds since then. A lot of my inspiration to do that came from health and weight loss content on YouTube. If you're familiar at all with weight loss and fitness content on YouTube in general, you may know the likes of Amron Reed.
It's like, I know how to lose weight, but I'm not doing any of it.
And Anna O'Brien, aka Glitter and Lasers.
Part of the reason I am overweight is because of the drama in my life.
Both social media creators who originally built their audiences by documenting their health journeys. If you go through their extensive back catalogs, you can see that Amberlynn's and Anna's journeys have been going on for over a decade. But since they started, they've actually gained a lot of weight and gotten even unhealthier. These two have garnered a lot of criticism over the years, but not just because of their weight loss attempts, but for a variety of reasons. I think a lot of the criticism for Anna and Amberlynn is justified, but I will be the first to tell you that weight loss is hard. I don't blame people like Anna or Amberlynn for struggling so much over the years. So many people try weight loss plan after weight loss plan, and when nothing works, they ask themselves, why? Why can't I lose this weight even when I'm trying so hard? Well, since I've been in this weight loss space, I've learned some people, including Anna and Amberlynn, have gotten an answer to that question in the form of a diagnosis, a disorder called lipedema. It's a condition that has a reputation for causing weight gain. My exploration of lipedema began at the end of April 2024 when Anna announced on social media that she was pursuing surgery for her lipedema. I had heard of this condition in passing, but Anna's description of it just sounded odd to me, and it compelled me to research it even further.
So, what is lipedema?
It's the abnormal buildup of adipose tissue or fat in the legs and arms, and it's special because this fat is not burnable by the body, which means diet and exercise won't have any effect on it.
Some people familiar with Anna and Amberlynn are skeptical of their lipedema diagnoses. After all, these two are notorious for saying questionable things about their weight. When they say they have a medical condition that prevents them from losing weight, a lot of people see that as another excuse to add to the list.
Eating 2,900 calories makes me gain weight. It does not make me lose weight. And then people call me a liar, but I would like to explain why. So when I saw the lipedema specialist, she told me, estimation, I have about 150 pounds of lipedema on my body. Large portions of that is on my legs, especially my calves, but that weight is not taken into account when you go into a TDEE calculator.
But it's not just them saying these things. I myself was very suspicious of Anna's and Amberlynn's descriptions of lipedema, but I've seen plenty of other patients and even experts insist that weight loss is very difficult or sometimes even impossible when someone has lipedema.
Not everybody has success with diet and exercise.
That's right.
And so if they come to you and you diagnose lipedema, what does that mean?
Well, lipedema is a fat disorder that's commonly confused with obesity, which is much more common. But lipedema is a type of fat accumulation. It tends to accumulate in the legs, and it is a type of fat disorder that does not respond to diet and exercise.
But some experts disagree. In fact, experts disagree about most aspects of lipedema. It's true that I started looking into this condition only because Anna and Amberlynn have it, but this video has very little to do with them specifically. To me, the controversy surrounding lipedema has become way more interesting. Also, if you're new to my channel and you're just here to learn about some medical conflict, I may reference these social media creators from time to time, but you don't need to be familiar with them to understand. Also, hi, I'm Colin. Glad to have you here. If you are familiar with my content, this is going to be quite the departure, but hopefully one you find interesting. If you like my little rabbit trail deep dives, I think you'll have fun with this one. There is going to be a lot of technical, medical language in this video, but I really hope you stick with me because it does get truly wild. But I have to set up a lot of background for you to truly understand why. I say I want to take you on a journey with me because it really was a journey. My only credential is a bachelor's degree in English, so let that be my disclaimer to you that I am not offering any kind of medical advice. I am simply presenting you with my research and my opinions about that research. I might get some things wrong just due to my own ignorance, and I apologize for that, but I also think I'm going to say some things that are up for debate, and that's kind of the point of this video.
Chapter 1. What is lipedema?
Okay, now then. What is lipedema? Well, even that is a point of contention. One basic definition I can give is that lipedema is a disorder which causes the overgrowth of fat on the legs and sometimes the arms, and it's usually associated with pain and easy bruising. This type of fat is more resistant to diet and exercise. There are 5 types or distributions of lipedema fat that are referred to in 4 stages of severity. If you're familiar at all with lipedema, you may have seen photos like these before. I've watched some other creators in the weight loss space give descriptions of lipedema, and that's usually about where they stop. And I think that's pretty much fine. Usually they're just giving a brief definition to catch the audience up to speed, and when you look up cursory information about lipedema, that's what you find. But the problem is, even that broad description I just gave is full of issues. For practically every word I said, there's a sect of professionals and patients who would disagree, or at least offer qualifiers. And a lot of those opinions would contradict each other. I also want to briefly mention before we go too much further that what we're talking about here is lipedema, not lymphedema. I know they sound similar and the conditions can even look similar, but they're 2 different things. Any kind of edema is swelling, usually referring to fluid. The way I remember the difference is that lipids are fats, so lipedema is a fat swelling condition, and lymph is a bodily fluid, so lymphedema is a fluid swelling condition. Some people pronounce lipedema as lipedema just to help differentiate between the two, so both those pronunciations are fine. Whenever I open my mouth, lipedema comes out, so I'll try my best to enunciate whenever I mention lymphedema, because unfortunately we're going to have to talk a lot about both. Lipedema kind of seems like it popped up out of nowhere recently, but it was actually first described in 1940 by doctors Edgar Allen and Edgar Hines. But it's kind of flown under the radar until recent years, and I think that's partly because it does get confused with other conditions, like lymphedema, obesity, or chronic venous insufficiency, which can cause blood accumulation in the legs. But I think lipedema has come into the forefront in recent years because of new technology, better research, and frankly, media attention.
It is estimated that more than 17 million people in the United States are currently suffering with lipedema. It strikes thin and overweight individuals, and no amount of diet or exercise can stop it. We spoke with Dr. David Amron, a board-certified...
I think there are a few reasons why lipedema has been under-recognized for so long. First of all, it's a pretty rare condition, depending on who you listen to. Second of all, over 99% of lipedema patients are female, and we as a society have a long history of overlooking conditions that primarily affect women. Third of all, let's be real, it sounds kind of questionable, doesn't it? There are some doctors who don't even believe lipedema exists, and on its face, I can kind of understand why. When a patient says, I eat right and exercise, but I can't lose this weight, I think a lot of doctors would be skeptical. It would take a lot of trust that the patient was accurately reporting their weight loss attempts, because human beings are terrible at recording these things. Watch an episode of Secret Eaters and you'll see that in action.
It's low-calorie cereal, isn't it? All healthy, good for you, so the more the merrier, I think.
Well, shall we find out? So let me introduce you to our expert dietitian, Lynn Garton.
Hi, Murray, how you doing?
Nice to meet you.
That bowl of cereal there contains 2,500 calories. So you've had your calorie intake before you've even got out of the door.
I'd never ever believed that.
That being said, there are some patients for whom it seems very obvious they have lipedema. For patients who are a healthy weight or even underweight, they can have a thin torso with disproportionately large limbs. It's hard to look at a patient like this and say, you just need to diet and exercise. There's clearly something else going on. But because lipedema is so rare and unknown, a lot of doctors would see large legs and diagnose the patient with lymphedema. That's the fluid one. I mean, look at these 2 patients, one with lipedema and one with lymphedema. Could you tell the difference? It's part of the reason why lipedema is so notoriously hard to diagnose. You need a trained professional who recognizes it, and if you and your doctor don't know what's going on, it's hard to know what type of specialist to look for. Usually it's lymphedema specialists or vascular specialists who end up diagnosing lipedema because these patients are just referred to them. This is where differential diagnosis is very, very important. Basically, a lot of the way lipedema is diagnosed is by ruling out other things. When a patient has disproportionately fatty limbs, pain, and bruising, and it can't be explained by anything else, there's a good chance a knowledgeable specialist will diagnose them with lipedema. That's because there's no definitive way to diagnose it. There's no tissue analysis, no blood test, no genetic test, nothing like that to determine if you have it. Recently, there has been research into a possible biomarker, meaning in the future we may have a blood test, but as for right now, diagnosis is purely clinical, meaning it's up to a medical professional's opinion. That's obviously an educated, expert opinion, but it's subjective nonetheless. There has been a ton of new research trying to find the cause of lipedema and develop a diagnostic test, but so far there's not been anything too concrete. Experts think that it's probably sex-linked or hormone-linked because over 99% of those affected are female, and males with lipedema typically have a hormone imbalance caused by another illness. And to make things even more confusing, you can have lipedema, lymphedema, venous insufficiency, and obesity all at once, or any combination of those things. These are all considered comorbidities, conditions that often occur together. In fact, in advanced stages of lipedema, it's so common to also have lymphedema that clinicians have coined the term lipolymphedema. So you can have just lipedema, just lymphedema, or you can have both, which is lipolymphedema. Are you still with me? You may be wondering at this point where I got all this information since I'm not even remotely a medical expert. In order to tell you the story of how I waded into this mess, I'll have to take you back to the beginning. A simple YouTube search, which I had to do in an incognito window now because all of this has wrecked my search results. If you look up lipedema, especially in the United States, it won't take you long to come across lipedema expert and researcher Dr. Karen Herbst.
And every time you gain weight, you grow a little bit more lipedema fat. That becomes very difficult to lose by diet, exercise, or even bariatric surgery procedures. And that is not your fault.
Dr. Herbst is an American endocrinologist, and she's dedicated most of her work to researching and treating fat disorders. And I soon found out that if I was going to talk about lipedema, especially as an American, I was going to have to talk a lot about Dr. Herbst.
Chapter 2, Dr. Karen Herbst.
If you live in the US and you were diagnosed with lipedema, I bet there's a good chance you've heard of Dr. Herbst. And I think that's because she's kind of a unique figure. Not only is she highly regarded by her professional peers, but she's also beloved by a lot of patients. It's not often a doctor or researcher reaches that level of familiarity with the lay public. And that's because she really puts herself out there. She's active on social media, she's giving talks, appearing on TV, holding Zoom lectures, even attending patient support groups. It's no wonder people like her so much. She seems like she genuinely cares about these patients. Her active online presence is really useful for patients and professionals trying to learn more, and for people making obscure YouTube videos. But arguably, Dr. Herbst is most famous for her work on the lipedema standard of care for the United States. There were 21 contributors on the lipedema standard of care, and we'll get to some of the other ones later, but Dr. Herbst was the lead author. This document is like the lipedema Bible for the US. It delves into a lot of the questions I had as I began my research, and it's extremely important to the whole conversation, so I just want to give a brief overview.
Chapter 3, The Standard of Care.
There are standards of care for many illnesses, but for the sake of brevity, just know that when I say the standard of care, I'm talking about the US lipedema standard of care. This standard of care is a guideline for how to diagnose and treat lipedema based on professional consensus. Dr. Herbst and her collaborators recognized that while some other countries, especially in Europe, had official guidelines for how to treat lipedema, the United States did not. It wasn't until 2021 that the United States finally published the standard of care in the journal Phlebology. In 2019, Dr. Herbst and her committee of other specialists assembled at a Fat Disorders Resource Society conference, and they arrived at a consensus about various statements related to the definition, diagnosis, and treatment of lipedema. This meeting was the jumping off point to the standard of care document. Now, the document itself defines consensus as at least 75% agreement from the committee, so I'm sure there are some differing opinions not stated in the final document, but I've watched enough of Dr. Herbst's talks and read enough of her papers to believe that she stands behind the majority of the statements, or at least she did at the time of publication. My impression is that she likely devised a lot of the consensus statements herself as the lead author. Here's how the standard of care defines lipedema. Quote, lipedema is a disease of fibrotic loose connective adipose tissue on the lower abdomen, hips, buttocks, and limbs of females, sparing the trunk, hands, and feet. Lipedema is rare in men. A trigger for the development of lipedema tissue may be an increase in fluid and connective tissue remodeling that occurs alongside body changes during puberty, childbirth, menopause, stress associated with lifestyle change, or by altering tissue structure after surgery or trauma, end quote. Sounds similar to my definition, but obviously a lot more in-depth. But as I've already discussed, there are some conflicting opinions on the definition that we'll get into later. One thing I noticed when I read the US Standard of Care and a lot of Dr. Herbst's other work is that she really pushes her own unique categorization of lipedema, which is a disorder of the loose connective tissue. And I'm starting to notice more and more professionals using this language as well. Dr. Herbst and her colleagues theorize that since fat is considered a connective tissue, lipedema could be a connective tissue disorder, similar to something like Ehlers-Danlos syndrome. And actually, Dr. Herbst is well known for studying the connection between lipedema and hypermobile Ehlers-Danlos syndrome. And can I be honest? I think a lot of the reason Dr. Herbst popularized the term loose connective tissue disorder is because fat and even adipose are such loaded words. You can't say the word fat without a million different implications floating through people's heads. Calling it connective tissue is much more neutral. There is another theory promoted by Dr. Herbst and other specialists that lipedema is caused by lymphatic dysfunction. Many experts believe lipedema can eventually progress into lymphedema, but Dr. Herbst is a little different. She argues that lymphatic dysfunction is present even in the beginning stages of lipedema, which could cause abnormal fat development, fibrosis, pain, and later lymphedema. Like the standard of care says, a trigger may be an increase in fluid and connective tissue remodeling. Lymph fluid is carried throughout the body via vessels of the lymphatic system, but if that system is weakened, then lymph fluid tends to settle in the legs. Dr. Herbst and her associates think this lymphatic dysfunction could trigger the development of lipedema fat. If you've been keeping up with Anna O'Brien, aka Glitter and Lasers, you may have heard her describe lipedema this way as well.
Hi, my name's Anna, and if you're new here, I have lipedema. And if you don't know what lipedema is, that's okay, because a lot of people don't. Basically, it's an adipose disorder or a fat disorder, which is caused by a leaky lymphatic system.
While it's not a confirmed theory, it is a very popular one. Like I mentioned before, lipedema and lymphedema are two different disorders. Lymphedema can cause a buildup of lymph fluid, and lipedema can cause a buildup of fat. But even though the disorders are different, lymphology is discussed a lot in the standard of care and in the lipedema research field as a whole. The disorders appear together so frequently, it's no wonder many experts believe there's a connection. That's probably why the pronunciation lipedema has gotten more popular. You rarely find lipedema discussed without lymphedema in scholarship, and that can get very confusing. But that connection is why the standard of care promotes wearing compression garments, using compression pumps, and getting manual lymphatic drainage, or MLD. MLD is a type of therapeutic massage that helps move stagnant lymph fluid. These are all very common prescriptions for lymphedema, but they've become common prescriptions for lipedema as well. They all fall under the category of what's called conservative therapy. They're all treatments to help manage the symptoms and prevent them from worsening, but they're not cures. The standard of care also states lipedema tissue is difficult to reduce by diet, exercise, or bariatric surgery. If you're familiar with lipedema, you've probably heard that before. A lot of people don't know about lipedema, but for those who do, I think diet-resistant fat on the legs is one of the most recognizable symptoms. Even though specialists say it's difficult to lose lipedema fat, the standard of care still acknowledges a healthy diet and exercise can improve it or at least prevent it from worsening. A lot of these experts especially recommend low-carb diets since they're considered anti-inflammatory, so that should help with the pain aspect of lipedema too. And of course, if you have typical non-lipedema fat on your body, you can still lose that fat with diet and exercise. The standard of care says that since lipedema fat tends to resist diet and exercise, in some cases, liposuction may be the best course of action. And as of right now, according to the standard of care, that's the only way to reduce lipedema tissue itself. There's no cure. all of these things, the conservative therapies and surgery, are just management strategies, which is why research has really ramped up in recent years. Because of increased visibility, researchers have recognized that there are a lot of people in the world suffering with this disorder. And not only is there no cure, but there's not even a reliable diagnostic test. Overall, despite a few differences, the US standard of care seems to recommend a lot of the same treatments recommended in other countries. Compression garments, compression pumps, MLD, anti-inflammatory diet, exercise, liposuction. And that all sounds pretty cut and dry, right? At the beginning of my research, I learned that although lipedema is rare and not yet explained, we have ways of treating it. Some people go a long time without diagnosis because their doctors just think they're obese, but they actually have this disease that causes persistent progressive fat growth. That's the same stuff I'm sure a lot of you have heard from the media and creators online. There's just one tiny little bitty problem.
Chapter 4, Dr. Tobias Bertsch.
This video would not exist if not for Dr. Tobias Bertsch. He's a German doctor who specializes in lymphology and bariatric medicine. He's also the founder and president of the International Lipedema Association. Like I mentioned before, information about Dr. Karen Herbst is abundant for the lay public, especially on social media. But Dr. Tobias Bertsch is a more typical doctor. He'll give a talk or a lecture here and there, but most of his work is in the clinic or in scientific publications. Just like Dr. Herbst, he is prolific in his field, but he doesn't have a Wikipedia page. Not to mention, he's German, so people in the US, like me, are gonna be way more likely to find work by the American Dr. Herbst and all the specialists who follow her lead. As messed up as YouTube's recommended feature is, it did somehow lead me to a video of Dr. Bertsch, which may have been the only reason I got into all of this. Honestly, I have no idea why it even stuck out to me because the video is simply titled Lipedema. It was a video of him speaking at a lymphology conference, and from what I can tell, the Canadian Lymphology Framework posted the video 3 years after this conference, and at the time of writing this, it has 60 views, and at this point probably a third of those are mine. I think the reason I clicked on it was because the thumbnail said paradigm shift. I went on to find out that the full title of the talk was International Consensus on Lipedema, Why We Needed This Paradigm Shift. And that sounded pretty compelling to me because in spite of how long we've known about lipedema, it's still a relatively young field of study. Research has really only ramped up in recent years, and medical science updates all the time. So I thought a paradigm shift implied there had been some recent breakthroughs. But what I found was actually kind of the opposite. Dr. Bertsch says in this talk that a lot of claims about lipedema, specifically from Dr. Herbst and other Americans, do not have sufficient scientific backing. Dr. Bertsch doesn't think lipedema is caused by lymphatic dysfunction, or that lipedema can lead to lymphedema. In his opinion, the term lipolymphedema is a complete misnomer.
There are still a few colleagues, mostly from the United States, who still believe in the traditional view of lipedema, believe that lipedema is an edema disease, and as a consequence, they recommend MLD for patients with lymphedema.
What's more, he even pushes back against the idea that lipedema fat is resistant to diet and exercise.
And please note, many self-proclaimed experts will tell you that weight loss has no impact on the lipedema. In fact, the opposite is true.
He doesn't think lipedema causes persistent weight gain, or that it always progresses through stages, like in those photos I showed before. He thinks MLD massage is pointless for lipedema, and he also thinks liposuction should not be recommended for a lot of these patients. This talk basically crumbled up the US standard of care and threw it in the trash. Now that is strange, isn't it? You have one side saying, look at our research, and another side saying, mine says the opposite. You see why it's taken me so long to make this video? What are we supposed to do with that? Dr. Herbst and Dr. Bertsch are both considered lipedema experts, but they hold basically opposite opinions. Some of you may be thinking, yes, but Dr. Bertsch could be a one-off wackadoo. The standard of care is composed by a whole team of experts. Well, like I mentioned, Dr. Bertsch is also the president of the International Lipedema Association, and they have a consensus document of their own.
Chapter 5, The International Consensus.
May I introduce you to the Anti-Standard of Care Committee, the International Lipedema Association, or ILA. Actually, the Standard of Care Committee might be the anti-ILA. Figuring out the timeline has been a little difficult since it seems they developed at about the same time, but the main takeaway is they are both groups of specialists, but they disagree on a lot of points. Much like the Standard of Care Committee, this international group of experts convened together in 2019 to create a consensus document. Theirs was published slightly earlier in 2020 in the Journal of Wound Care. Initially, there were 24 authors from various European countries, led by Dr. Bertsch. But the consensus group expanded and created the ILA in 2021, which includes many more members from all over the world, including the US. And the ILA has this consensus document available on their website as kind of their official stance. Their document is titled Lipedema, A Paradigm Shift and Consensus. Dr. Bertsch was the lead author, and obviously in that paradigm shift talk, he was referring to this document. That title is kind of a mouthful, so I'll refer to it as the International Consensus. So, to review, in the US, we have Dr. Herbst' Standard of Care. And mostly in Europe, we have Dr. Bertsch's International Consensus. It's worth noting that unlike the Standard of Care, the International Consensus members reached 100% agreement on all the statements in their document. And the main reason they created this consensus document was because they wanted to dispel what they call rampant myths surrounding lipedema. The International Consensus defines lipedema this way, quote, "Lipedema is a chronic condition characterized by a disproportionate increase in adipose tissue and pain in the legs and sometimes the arms of women. Its prevalence is largely unknown. The disproportionate increase in weight around the legs usually starts in phases of weight gain that are mostly connected to hormonal changes such as puberty, pregnancy, and menopause. Years later, and mostly after further weight gain, pain or the feeling of severe heavy legs may occur, at which point the condition meets the diagnostic criteria for lipedema," end quote. That is in stark contrast to the US Standard of Care. Well, at first glance, the differences may seem pretty subtle, but they pack a punch when you consider the implications.
Chapter 6, The Debate.
So, let's compare these two sides. First of all, we'll look at where they agree. Both acknowledge that the condition causes weight gain in the legs and arms that usually appears around hormonal shifts. They also both note symptoms of pain and impaired mobility. They do agree about a few treatments like good nutrition, exercise, and compression garments. But that's about where the similarities end. In comparison with the Standard of Care, the International Consensus is actually pretty simple. Lipedema is a condition of disproportionate fat on the limbs and pain, and those symptoms are often correlated to typical weight gain. The Standard of Care includes a lot more speculation. Anything from hormones to stress to surgery could cause lipedema. The tissue itself is described as scarred and fibrotic, which could lead to pain, and perhaps most importantly, the lymphatics and fluid edema could be involved in the development of the fat. It can be argued that the International Consensus is way more focused on disputing those claims than making their own claims. There are quite a few points of contention in the International Consensus, but I just want to hit on the major ones.
Contention 1. What is lipedema?
One distinction between these two documents, believe it or not, is how they categorize what lipedema is. Dr. Herbst's group often calls it a disease of the loose connective tissue.
And that's why we like to say that lipedema is a connective tissue disease, because of all the other constituents of the tissue that are important, not just the fat cell.
Dr. Bertsch's group calls lipedema a syndrome of unknown origin. I have seen the ILA use the terms disease and syndrome kind of interchangeably, but I do know Dr. Bertsch in particular always emphasizes lipedema is a syndrome. He actually goes out of his way to call it lipedema syndrome.
Lipedema is a syndrome, and I would like to explain what is the difference between syndrome and disease. And a syndrome refers, as you probably know, to a group of symptoms, while a disease refers to an established and well-defined medical condition. And lipedema syndrome, ladies and gentlemen, is by far not a well-defined medical condition. We don't have any lab values, no histology findings, no ECG findings that tells us this patient is suffering from lipedema syndrome.
There are those who assert they do know the cause and course of lipedema, and they all have different opinions. A bunch of those people did get together to hash it out for the Standard of Care, and they still weren't able to come to a conclusion. I mean, the standard of care calls lipedema a disease, but speculates it could be caused by all kinds of things. Puberty, childbirth, menopause, stress, surgery, trauma, lymphatic dysfunction, a connective tissue disorder. The international consensus simply says, we don't know yet, but maybe it's genetic.
Contention 2, is there edema in lipedema?
One of the most emphatic points in the international consensus is that the authors believe there is no evidence of fluid edema in lipedema. This is maybe the biggest source of contention between the two sides. The name lipedema is really confusing because edema usually does refer to a swelling of fluid, but lipedema is a swelling of fat. But like I said, Dr. Herbst believes that lipedema could be caused by lymphatic dysfunction, so she does believe there is fluid edema in lipedema.
There is a defect in the early lymphatic endings, and maybe even a subtle defect in the larger connecting lymphatics. So the lymphatic system just doesn't function maximally. This fat depot compresses the lymphatics, which are already slightly dysfunctional, and that excess fluid is a rich environment for inflammation, but also for fat to grow.
To dispute this theory, the international consensus provides ultrasound images showing the fluid present in tissue with lymphedema versus the lack of fluid in lipedema tissue. And in the talks that I've seen, Dr. Bertsch also shows 3D imaging to demonstrate there's no fluid in lipedema.
This is a control group. This is a normal, a healthy patient. And these are the lymphatics of these patients. They are completely healthy. And here you see the lymphatic system of a lymphedema patient. You see a chaotic organization. You see the decongestion, the dilated lymphatics, different calibers. And this is a patient with lymphedema, completely normal lymphatic system.
Dr. Bertsch argues that if lipedema really is a lymphatic disorder like lymphedema is, why would we not see any fluid? Now, Dr. Herbst and her colleagues argue that the edema is difficult to see with most imaging techniques. And there has been a recent study co-authored by Dr. Herbst that shows lipedema patients in the study tended to have more of what are called hyperintensities or bright spots on imaging called lymph angiography. That suggests there could be edema in these patients' legs, but this is the only study I've seen that's found this. I did see one other study co-authored by Dr. Herbst that tried to find fluid, but the results were largely speculative and inconclusive. They looked at abnormal vessels in lipedema patients and speculated that the abnormal vessels could cause fluid leakage, but they still weren't able to determine the presence of fluid.
Space was used as a surrogate measure of the amount of interstitial fluid.
More importantly, there are other studies using a variety of imaging techniques that did not find any fluid in the tissue. All of the authors of the International Consensus report that their pure lipedema patients did not have any fluid accumulation, and they cite several published studies with the same findings. Why is this so important? Well, if the international consensus is correct that there's no edema in lipedema, that would completely alter the way it should be treated. I mean, titling this paper a paradigm shift was no joke. Basically, every treatment plan that I've heard of includes recommendations that help improve lymphatic flow, or in other words, treat edema. And while patients with lipedema sometimes do have the fluid condition lymphedema as well, the international consensus asks, well, for patients with pure lipedema, why are we recommending these things? Things like compression, MLD, pneumatic pumps, vibration plates. The international consensus says there's no evidence that those treatments actually help with lipedema because there's no evidence of fluid. Well, one addendum. Dr. Bertsch and his colleagues actually do recommend compression garments, but only because they think that does help with inflammation and pain, like how athletes wear compression. But things like MLD and compression pumps, according to the ILA, seem completely pointless for pure lipedema. That is quite the paradigm shift. Things that have been recommended for years as absolutely imperative treatment for lipedema might not be necessary. Obviously, pain management is necessary, but compression isn't going to help reduce the fat swelling or prevent future fat growth, in the ILA's opinion. And people like Dr. Herbst and her colleagues disagree.
And fluid moves down with gravity, and so lobules tend to get bigger over time. And therapists, manual lymphatic drainage therapists, can reduce the size of lobules and provide compression garments that can contain those lobules. And there are now compression garments specific for lobules. So I think getting to a therapist and making sure that as you make your decisions that your lobule doesn't increase in size is really important.
The other reason this fluid issue is so important is because of the debate around lipolymphedema. Dr. Herbst claims that lymphatic dysfunction causes lipedema and that advanced stages can lead to lymphedema. Dr. Bertsch believes any lymphatic dysfunction in these patients is secondary and it's caused by another condition entirely: obesity.
Contention 3, obesity.
You may already know that many obese people develop lymphedema. Excess weight can impair the lymphatic system, which causes a buildup of lymph fluid, usually in the legs. A lot of that is just due to gravity. When you have a weak lymphatic system, it's hard to pump fluid uphill, so to speak, so it often settles in the limbs, usually the legs and/or arms. This condition is extremely common in obese people, and most people with advanced lipedema are also obese.
You should know that around 85%, and we have studies all over the world who say the same, around 85% of our patients with lipedema syndrome are obese, have a BMI more than 30.
And in Dr. Bertsch's opinion, that very common obesity is likely the cause for the associated lymphedema.
That's very important for me to emphasize this. This is an obesity-associated lymphedema. This is not a lipedema-associated or lipedema-induced lymphedema. We have no pathophysiology why lipedema should cause lymphedema, but we know very well why obesity is inducing lymphedema.
People do often make the point that BMI is not always reliable for lipedema patients, so Dr. Bertsch also uses the waist-to-height ratio to determine if a patient's lipedema is kind of throwing off the BMI scale. To be clear, the ILA is not saying that lipedema is just obesity. Instead, what they're saying is that many or most lipedema patients also have obesity, and that obesity can often make lipedema symptoms worse. In Dr. Bertsch's opinion, obesity is the much more urgent issue that needs to be addressed first and foremost.
It's lipedema plus obesity, and to focus on lipedema in patients like these, and to ignore the disease which is in the foreground, the obesity, is the same as when your house is on fire and you put out the fire in the garage.
The standard of care asserts that lipedema is often confused for obesity, meaning that some patients aren't actually obese because of their lifestyle, but it's just their lipedema making them appear that way. And that's somewhat understandable. For some patients, if a doctor only looks at their BMI and not their body fat distribution, they may get the wrong impression. I think about those patients who have thin torsos and large legs. However, that's not exactly the point Dr. Herbst and her colleagues are making. One of the more controversial beliefs some specialists like Dr. Herbst hold is that lipedema can affect more parts of the body than just the arms and legs. Like I said before, the standard of care's definition of lipedema is a disease of fibrotic loose connective tissue on the lower abdomen, hips, buttocks, and limbs. That definition begins with lower abdomen, and I have to think that's not a coincidence because that's such a controversial opinion. It seems like they might be subtly emphasizing that belief by listing it first. And actually, that's kind of a conservative representation of that belief. Dr. Herbst and many of her colleagues are on record saying that lipedema could affect not just the arms, legs, and lower abdomen, but theoretically, they believe it could be anywhere subcutaneous adipose tissue is found.
This is Dr. Wright, and I have a very special guest today. Dr. Karen Herbst is here visiting my clinic. So what we want to talk about is, does lipedema occur in the trunk? And this is something Dr. Herbst and I feel very strongly about, but is somewhat controversial because our European colleagues say it does not occur in the trunk, and we believe it does.
Agreed, completely. And I think that really lipedema is a systemic disease. It just manifests because of a variety of reasons, primarily because of gravity in the legs, so from the abdomen on down, but also in the upper arms. It's a little, I don't know, we can't explain it as well as gravity, but there is a big piece of fascia on the elbow that holds the tissue. So if fluid were to leak down, it's going to accumulate above the elbow and then build up. So again, gravity might be a big player in why we see it on the limbs, but that it can really occur anywhere.
So that would mean that a patient could present as a typical obese person with increased fat on their whole body, and all of that fat could be attributed to lipedema. And while that line of thinking isn't so clearly spelled out in the standard of care, we find it often from the authors in other places.
The abdomen is heavy, and this is also a point of contention, is the abdomen affected in lipedema? And if you attended our research webinar this month, you would have heard Dr. Sinti say that he thinks that lipedema is a systemic disease, and I agree.
So something I want to talk to people about, and that is abdominal lipedema, or lipedema that happens usually in the abdomen. Could be the sides, the flanks also.
I kind of wonder if that belief wasn't included in the standard of care because other members of the committee pushed back against it. I believe Dr. Herbst and her colleagues would argue that not everyone with lipedema has it in the abdomen, but they are very open to the possibility. Publications in other countries, and even most in the US, say that lipedema can affect the legs and sometimes the arms. But Dr. Herbst would even debate that statement, since she believes that about 80% of patients have it in their arms. But this is all extremely difficult to determine, since there's no reliable way to examine the fat and say, this portion is definitely lipedema, or this portion is definitely regular fat. I have seen various specialists say you can identify lipedema fat by feel. They say it's usually hard, nodular, and fibrotic, but the problem is that obesity can also cause fibrosis, and cellulite often looks and feels the same way. So this diagnostic technique is debated as well.
Contention 4, is lipedema progressive?
Another major difference between these two documents, the standard of care and the international consensus, is about whether lipedema is necessarily a progressive condition. Does the fat typically grow over time? The standard of care says yes, and even publications outside the US agree. Lipedema does get progressively worse, and they will describe lipedema as having stages of severity. Remember these pictures? Yeah, those are not all pictures of the same woman over time. Those pictures show different women at each stage. The international consensus says these types of images cause both patients and professionals to believe that this condition will always get worse over time. But in fact, Dr. Bertsch gives examples of patients he's seen who maintain a stage 1 or 2 for decades.
Do you see progression of the disease in your lipedema patients like we always see in lymphedema?
I love this question. Great question. Lipedema is not progressive. It's not a progressive disease. We see patients now at the Felicitie clinic, we treat over 20, 30 years who are completely stable because the weight is stable. When the weight remains stable, lipedema syndrome also remains stable. But what we in most cases see that the weight is gaining, that obesity is progressive.
Dr. Herbst believes that lipedema causes fat growth. So even if a patient diets and exercises, their lipedema may continually grow for the rest of their life. In her opinion, a calorie deficit really wouldn't help.
And if we talk about compliance of tissue again, remember if you have very compliant tissue, as you grow more fat tissue, your body just allows that to happen. It doesn't have that elasticity. If you look at that graph, as you lose compliance, you increase the amount of aromatase enzyme, you increase the amount of local estrogen within the tissue. And what happens when you do that? You decrease fat breakdown. So if you have more fat on the lower part of your body, you may be generating more estrogen locally, and you may be reducing the breakdown of fat, contributing to an inability to lose weight with diet, exercise, or bariatric surgery.
Dr. Bertsch would say, no, the weight gain is due to a calorie surplus, just like everyone else. There are a couple of images I showed earlier of women with thin torsos and large legs, and the international consensus claims that these examples are extremely rare. Thin women with lipedema typically only have slightly noticeable disproportion, and it doesn't progress as long as their overall body weight remains stable. People who fall into the category of stage 4 or even stage 3 are nearly always obese or morbidly obese.
Contention 5, is lipedema painful?
Dr. Bertsch and the ILA would argue that the disproportionate fat itself isn't enough to qualify someone for a lipedema diagnosis. There's one other major symptom they would have to have: pain. The standard of care states that lipedema tissue may be very painful, whereas the international consensus states that pain is required to meet the diagnostic criteria for lipedema. Just to repeat again, the ILA believes that if you only have larger legs, that's not enough to qualify for a lipedema diagnosis. You would also have to experience pain in the fat tissue. Other specialists are a little fuzzy on that point. Usually they'll say something like, lipedema may be painful, or lipedema is usually painful. It's quite a distinction for the ILA to insist that lipedema must be painful. That's part of the reason why Dr. Bertsch and his colleagues actually proposed to change the name of lipedema. Number one, they don't believe fluid edema is involved, and the name confuses that point. And number two, they want to emphasize that this is better categorized as a pain disorder. One proposed name in the international consensus is lipalgia syndrome, which would mean painful fat syndrome. It's interesting to me that these two groups seem to split their focus between the two major aspects of lipedema, fat versus pain. Dr. Herbst and her colleagues seem to be very focused on the development of the fat and what could be causing it. Dr. Bertsch and his colleagues believe that the fat develops just like everyone else's. They're more focused on finding out why it's painful. They both care about both of these aspects, but their different reasonings behind why these symptoms occur means their treatment methods are also very different.
Contention 6. Treatments.
They can agree on compression, but they recommend it for different reasons. Dr. Herbst believes patients need compression with garments, pumps, and MLD because these treat lymphatic dysfunction, fluid edema, and potentially she thinks these treatments could slow the progression. Dr. Bertsch believes compression garments help with pain, but the other treatments are unnecessary since there is no edema. And compression wouldn't stop fat growth since he believes that's caused by regular weight gain behaviors. Both sides agree that patients should try to eat healthy and exercise, but again, Dr. Herbst recommends exercise largely to increase lymphatic flow, while Dr. Bertsch recommends this to prevent further weight gain and improve mobility. One of the other major differences between these two viewpoints are their surgical recommendations. For morbidly obese patients, Dr. Bertsch recommends weight loss surgery. Weight loss surgery would address the more urgent issue of obesity, which may help improve lipedema as well.
Please note, many self-proclaimed experts will tell you that weight loss has no impact on the lipedema. In fact, the opposite is true. As you can see here, the volume of the thigh at the y-axis and the time after surgery, the first and the second year at the x-axis. And patients with lipedema lost the same amount of volume in the thigh as the control group, even a bit more.
But Dr. Herbst claims that weight loss surgery may not help with lipedema symptoms. She isn't against it, and she's even said she has recommended it for some patients, but she thinks weight loss surgery doesn't always improve lipedema limbs. And theoretically, it wouldn't help those patients who have whole body lipedema at all.
This is a woman who was a patient of mine. She also has obesity and lipedema. So in blue shorts, it's before sleeve gastrectomy, and in the gray shorts, it's after sleeve gastrectomy. And you can see she did lose weight on her abdomen, which is great. She also lost a little weight on her arms, and you can see that her cuff actually improved after the surgery. So I think surgery does help the obesity component of lipedema. It may also help the lipedema component, but it does not get rid of all the lipedema tissue.
Instead, she thinks a lot of these patients, regardless of weight, should receive liposuction. Dr. Bertsch isn't against liposuction, but he doesn't recommend it for most patients. These are radically different treatment plans. Do we recommend pumps and MLD or not? Do we recommend bariatric surgery or liposuction? And what are our expectations for these treatments? This is why figuring out the cause of lipedema is so important. It's hard to know how to treat something when the experts can't even agree on what it is. From what I've seen, a lot of popular treatment plans just borrow from lymphedema treatment plans. It's almost a metaphor for how lipedema patients get lost because both the name and the symptoms get confused for lymphedema. There's no argument that Allen and Hines thought there was fluid edema when they first coined the term lipedema in 1940, but Dr. Bertsch argues it's time for a paradigm shift because that's an outdated and scientifically unsupported view in the modern day. Dr. Herbst pioneers ahead with more and more research into the fluid aspect of lipedema. Is that a waste of time? I would say not necessarily, because any research into the cause of lipedema would be useful, right? One problem, though, is when everyone can't even agree which patients qualify for the diagnosis, which may potentially skew the results of studies. Dr. Bertsch's group would only diagnose a patient with lipedema if they had disproportionate fat on their limbs and pain within the fat tissue. Dr. Herbst's group may still diagnose someone with lipedema if they have no pain. So that begs the question, if someone did have disproportionate fat but they have no pain, what does Dr. Bertsch and the ILA think they have?
Chapter 7, Differential Diagnosis.
A lot of illnesses share symptoms. Misdiagnosis is frustrating, but sometimes doctors do have to kind of troubleshoot to figure out what's wrong with you. For every diagnosis, there's usually a list of differential diagnoses, other possible diagnoses that could fit your symptoms. Lipedema is no different, except because it is a clinical diagnosis with no reliable test, there's a lot more troubleshooting involved. Other possible diagnoses are lymphedema, obesity, venous insufficiency, and if you have no pain, you might have something called lipohypertrophy. Now, this is something that's also quite controversial. Someone like Dr. Herbst may see someone who has disproportionate fatty limbs but no pain, and she might still diagnose that person with lipedema. Someone like Dr. Bertsch would say, no, if you have no pain and no symptoms of disease, then you may just have lipohypertrophy. And all that means is someone has excess fat on their legs. It's not even necessarily a diagnosis per se. It would be somewhat equivalent to diagnosing someone with cellulite. Dr. Bertsch says lipedema always stems from lipohypertrophy, but lipohypertrophy itself is not the same as lipedema. It's kind of like how a square is a rectangle, but a rectangle is not a square. Fat distribution is largely genetic, and if the only problem someone has is that their legs are bigger than average, that doesn't necessarily mean they have an illness. I mean, Dr. Bertsch even goes so far as to say that one differential diagnosis is just healthy legs.
Now, this is, in my view, the most important differential diagnosis, healthy legs. What is disproportionate and not is often determined by the spirit of the time, by the Zeitgeist, the German word Zeitgeist. And it would be wrong to say that only women with this body or leg shape or this have normal legs and the other three, they have sick legs. And it would also be wrong to say that only the lady in the middle has normal legs and the other legs are sick or are ill.
That's why to him and his colleagues with the ILA, pain is essential to the diagnosis. If there is no inflammation, there's no pain, then there's really no reason to go through all the stress and cost of the treatments for lipedema. Of course, this type of person could opt for cosmetic liposuction, but if this isn't relieving any symptoms of illness, insurance or the government would probably not pay for it. And it's hard enough to determine lipedema in a healthy weight person. It's arguably more difficult to diagnose lipedema in an obese person because they just have increased fat in general. It's sometimes hard to tell if an obese person is actually disproportionate since excess fat can be distributed in so many ways. It's also common for obese people to experience musculoskeletal pain. So it's more difficult to identify if their pain is isolated to their joints and muscles because of obesity or in the fat tissue because of lipedema. One thing that both sides can agree on is that mental health is a huge aspect of lipedema. A lot of patients struggle with depression, anxiety, and self-image issues, and both sides recognize that treating a patient's mental health is just as important as treating their physical health. But perhaps the most controversial opinion Dr. Bertsch and the ILA hold is that some lipedema patients could be suffering from psychosomatic pain. Now, here's where we have to acknowledge a few things. Dr. Bertsch is a man, lipedema affects women almost exclusively, and for basically all of human history, women's health has been dismissed and mishandled by men. I recognize I'm also a man talking about a mostly women's issue, but I hope you will grant me some compassion when I say I think Dr. Bertsch does make some good points. I've watched his few talks that are available online and read some of his papers about lipedema, and he usually offers this differential diagnosis in all of them.
And of course, our patients suffer from pain in the soft tissue of the legs, sometimes the arms. But the pain perception, as I showed, is strongly connected with the mental stress, the depression, the stress level of our patients. And of course, they suffer also from their mental issues. Patients with lipedema syndrome suffer from weight gain. As I said, 85% are obese, 50% are morbidly obese. And many of them suffer from a poor fitness. I can't walk the stairs. And when they They feel stigmatized because that obesity is stigmatized in our society. And of course, they suffer of a lack of self-acceptance because of the current ideal of beauty.
And this was one I initially struggled with. I admit it took me a few times to fully listen and understand what he was saying because initially I thought he was being dismissive and frankly a little misogynistic. He's basically saying that someone who doesn't fit the impossible beauty standards in our society, say someone with larger legs, may experience such intense dissatisfaction and self-consciousness that it manifests with physical pain. He also notes that a large percentage of lipedema patients had mental disorders that existed before their symptoms of lipedema began. A lot of people would interpret him saying that as dismissing these women's pain, which is a problem in the medical field. And initially I kind of thought that too, but now I personally don't 100% agree that's the case here. I hope this doesn't come across as dismissive on my end as well. It's a story that's much too long to tell right now, but I have experienced psychosomatic pain and experienced the effects of a placebo. Believe me when I tell you, I struggled to understand my own experience for years, and I only recently came to realize that my problem very likely was all in my head. I think a lot of nuance gets lost when people say, oh, it's all in your head. People often say that to be dismissive, but I do genuinely believe that that's sometimes true. And just because a problem is mental doesn't make it any less real or impactful than a physical problem. The only difference is how you go about treating it. I think Dr. Bertsch and his colleagues would agree to that statement. After all, they do recommend the same treatments regardless of where they think the pain comes from. And whether or not the pain itself is caused by mental issues, therapy is often recommended for lots of people living with pain disorders, because living with a chronic condition can be mentally taxing for anyone. But a lot of people hate that take, including Dr. Herbst's committee and many patients. And I can understand why. I don't think it explains all or even most lipedema patients' pain, but I also don't even think Dr. Bertsch thinks that, because he says that the most likely causes of pain in lipedema are inflammation and tissue hypoxia. But he still thinks psychosomatic pain is a worthwhile differential diagnosis to consider for a small percentage of these patients. People like Dr. Herbst would argue that living with this painful condition is what causes the mental distress. And I agree. I can see both sides of this argument, and I also don't think they're mutually exclusive. I see both sides argue their points as if they both can't be true at the same time, and I think that's pretty silly, but there is one aspect of Dr. Herbst's argument that I don't necessarily agree with.
The development of depression and anxiety in people with lipedema is likely multifactorial, including from the lipedema tissue itself. So if you have depression or anxiety, don't beat yourself up about it. It's not a weakness that you have. It actually could be because of the hormones that are being released by the lipedema tissue itself or through hypermobile joints.
And frankly, I don't think she has sufficient evidence to be making this claim. Something else Dr. Bertsch refutes is the idea that obesity itself could be a differential diagnosis. So a doctor could say, right or wrong, you don't have lipedema, you're just obese, or they could say, you're not obese, you just have lipedema. That's something you'll see a lot in the literature, and I've even called obesity a differential diagnosis a few times myself. But the problem, Dr. Bertsch says, is that quite often for lipedema patients, they have both.
Obesity is definitely not a differential diagnosis of lipedema syndrome. Definitely not. Obesity is in most cases neither a misdiagnosis nor differential diagnosis. Obesity is an additional diagnosis, and in most cases, it is the main diagnosis.
What does Dr. Herbst's committee think? Well, we've already heard a few of their opinions, but I think we also need look no further than her paper, titled Rare Adipose Disorders Masquerading as Obesity. She includes lipedema as one of those disorders. You may have noticed that it's mostly the ILA offering differential diagnoses, and that's simply because Dr. Herbst and her colleagues don't seem to focus on it as much. Most of the time when they discuss other diagnoses, they're talking about the overlap between those and lipedema, because there are indeed a bunch of comorbidities. Or they're mentioning other illnesses in the context of people being misdiagnosed before they get a lipedema diagnosis. That isn't to say they don't think there are differential diagnoses, because they definitely do, but I would argue that they don't discuss or encourage differential diagnosis nearly as much as the ILA does. Now, at this point, we've gone over a lot of technical things, and I appreciate it if you're still here with me. And if you feel like your brain is being pulled in too, join the club. My stance vacillated so wildly between these two standpoints and everywhere in between while I was doing my research. I started out listening to Dr. Herbst just because she was easy to find, a leading researcher, and she seemed to have a lot of knowledge about this condition. But I couldn't reconcile her belief that lipedema could cause spontaneous weight gain because of the laws of thermodynamics. I mean, I'm not an expert. I will once again reference my English degree, but I will say I am biased against that view because I myself have lost a lot of weight through calorie counting. I have a basic grasp on how energy storage works. Excess calories are stored as fat, and in order to burn that fat, you need to be in a calorie deficit. The laws of physics do indeed apply to the human body, so you can't create fat out of nothing. So I thought maybe lipedema affects a person's metabolism. But could it affect the metabolism to this degree? There are patients who look like this, falling into the category of morbidly obese, and they claim they starve themselves. And some professionals stand behind that claim, stating that lipedema severely lowers metabolism.
And eventually it will begin to slow your metabolism down because this fat is not only responding to hormones, it's producing estrogen and other hormones that progressively makes it harder and harder to lose weight. So usually about stage 2, she just begins to lose the whole battle with it, and she can find herself starving, eating very, very little, and she's still putting on weight, right?
I personally didn't understand how that could be possible. How could someone starve and gain weight to this level, even if they did have a lowered metabolism? Most of my skepticism came from that claim. I couldn't understand how a leading expert like Dr. Herbst held this view. She is highly respected in the scientific community, but it felt like her views didn't match up to basic physics. But then again, I'm no scientist. When I discovered Dr. Bertsch, it felt like his view explained everything. But then the other side, or experts landing somewhere in the middle, presented opposing research that seemed compelling. There are experts with opinions all over the spectrum, with their own research and studies with contradictory findings. I found it fascinating and confusing, and it's what led me to making this video. And I was tempted to end right here and say, I guess we'll just have to wait for newer, better research. But I was frustrated by my own lack of understanding, so I decided to try to dig deeper, and I was totally unprepared for what I found.
Chapter 8, Dr. Karen Herbst, Part 2.
I mentioned before that Dr. Herbst is extremely easy to find online. She's featured in a lot of YouTube videos, and those were some of my first exposures to lipedema research. Sometimes she gives talks, sometimes she presents her own research and theories, sometimes she answers patient questions. And I have to say, it was very hard for me to hang with a lot of these videos because it's a lot of technical language I don't understand.
Also within the extracellular matrix are immune cells like macrophages, eosinophils, mast cells, but there are also fibroblasts which stimulate inflammation. And one of the most important parts of the extracellular matrix is hyaluronic acid, or hyaluronin, which is the red line shown here. And you can see that hyaluronin interacts directly with the cell, and it binds up other proteins to which other glycosaminoglycans bind. So hyaluronic acid is a glycosaminoglycan. It's a sugar molecule, but it doesn't have a negative charge. Whereas other glycosaminoglycans, like on that brush-looking structure, do have a negative charge. When we talk about connective tissue, we're talking about cells such as fibroblasts and chondrocytes in cartilage, osteoblasts, and osteocytes in bone. But in fat, it would be just the fibroblasts. But there are also fibers, which I've mentioned, collagen, but also elastin and other elastic fibers. And then there are these proteoglycans and glycoproteins, which I'll talk about. And then you've got your tissue fluid.
I've heard her say glycosaminoglycans enough times that I can pronounce it, but I couldn't tell you off the top of my head what they do. At the beginning of my research, I went back and forth between Dr. Herbst's videos and those by Dr. Bertsch and other experts, and at first, I didn't know who to believe. I did lean more towards Dr. Bertsch's views when I found him because they seemed more logical, but Dr. Herbst presented so much more research, more theories, more content in general, and trying to square all of Dr. Herbst's in-depth explanations with Dr. Bertsch's relatively simple ones was somewhat difficult. I came away from these videos with way more questions than answers. Was Dr. Bertsch just not aware of the most recent research? Did he and the ILA have alternative explanations for the things that Dr. Herbst was saying? Did anyone? I tried looking up these concepts, but again, I'm not medically trained, and so a lot of the studies I found went way over my head. I knew there was disagreement, but I didn't know enough to explain what the disagreement was at like a cellular level. But the more I watched Dr. Herbst's many available talks on YouTube, the more questionable things I began to notice. No matter how technical her language was, I did know enough to spot things that seemed off. One of the more troubling talks I saw her give was at a Fat Disorders Resource Society conference. The Fat Disorders Resource Society, or FDRS, has a YouTube channel where they post recordings of past conferences. This conference is very important to the lipedema community, professionals and patients. You may remember this was the same conference at which the standard of care was proposed, although the talk I'm about to go over was slightly earlier in 2016. This talk was entirely dedicated to different supplements, vitamins, and medications that could possibly help with lipedema.
I cannot do all medications and supplements in 30 minutes. There's just no way. So I kind of picked and chose.
Now don't get me wrong, I think there are plenty of benefits to supplements and vitamins, as long as you take them properly and preferably with a doctor's supervision. And Dr. Herbst does advise talking to your doctor first, especially because many supplements can interfere with medications. But here's the problem. I counted at least 40 suggested treatments in this talk. Some of them made a lot of sense to me, like weight loss medication.
But epinephrine comes from your sympathetic nervous system. You can also get it from amphetamines. And if you've ever been to my clinic, it's a good chance that we talked about amphetamines. And these include things like dextroamphetamine, Adderall, and phentermine. And phentermine is a medication that's used in obesity.
A large percentage, and possibly even the majority of lipedema patients are obese, so sure, that sounds reasonable. She also recommends things like drinking lemon water.
Just to let you know that amphetamines are one way to bring these big fat cells down to a more normal size. The other thing that does it is lemons. Do you believe it? But look at that huge list. Just from squeezing a lemon and maybe taking a little bit of that peel and putting it into your water.
And then she recommends vitamin D and vitamin C. Oh wait, actually she recommends taking over 8 times the recommended dose of vitamin D and over 26 times the recommended dose of vitamin C.
So take your vitamin D daily, that vitamin D, and you get your blood levels checked and it's not there. And you're like, I'm taking 5,000 units a day and it's not enough. That's okay, take more.
The recommended daily amount of vitamin D is 600 IU for people ages 1 to 70 years.
Vitamin C, the recommendations from this paper are 200 milligrams a day. I think 2,000 milligrams a day is better.
The recommended daily amount of vitamin C is 75 milligrams for adult women.
And then she recommends eating apricot seeds.
There are many other seed extracts. I know some people eat like 2 apricot seeds a day.
And that's especially concerning because if you didn't know this, apricot seeds contain a chemical that the body converts into cyanide. I hate to say it, but this talk made me lose a lot of respect for Dr. Herbst. I mentioned before on my channel that I have a morbid fascination with pseudoscience, and I recognize these things, the mega doses of vitamins and apricot seeds, as popular but questionable alternative medicine. So obviously this worried me, especially because she's trying so hard to have it both ways. She's a respected scientist trained in conventional methods, and she does recommend real tested treatments like healthy diet, exercise, weight loss medication, but she also knows that she's recommending vitamin doses way higher than what's recommended by other doctors. She says to consult your doctor before taking these things, but how many doctors would sign off on megadosing vitamins? And you will be hard-pressed to find any respectable doctor who recommends eating apricot seeds. In fact, the FDA actually recommends against ingesting apricot seeds because of the cyanide poisoning risk. The chemical in apricot seeds, amygdalin, also known as Laetrile or vitamin B17, is first of all not a vitamin, but it is a popular alternative treatment promoted mostly for cancer, so it's weird she's recommending it for lipedema in the first place. More importantly, aside from the cyanide poisoning risk, it's never been proven to help with anything. That can be said for a lot of the supplements Dr. Herbst recommends in this talk. And while there has been some research that shows possible benefits to taking some of these supplements, the evidence isn't strong in general and completely untested for lipedema. The most I can say based on my research is that a lot of these things probably won't hurt you in recommended doses. Even 2 small apricot seeds may not hurt you in the long run, but are lipedema patients just supposed to be choking down 8 million different supplements every day with lemon water? That's a big ask, so where is the evidence that this is helping them? And I know I'm just inviting a lot of arguments about how these supplements really do help. I clearly haven't learned my lesson from previous videos, and if they do help you, I'm glad. But my point is, I think a researcher, a doctor, should not be recommending potentially dangerous doses of vitamins, supplements that haven't even been tested for lipedema, and cyanide. As far as I'm concerned, if my doctor recommended all this stuff, I'd be out the door fast looking for a new doctor. The most troubling part of this talk for me is that the audience is full of patients. And what if one of these patients goes to their doctor and says, "Hey, I eat 2 apricot seeds every day," and their doctor says, "Please don't do that, it could be dangerous." One would hope that the patient would take their doctor's advice, but well, I think there are a lot of lipedema patients who take whatever Dr. Herbst says as gospel. And what's more, so many lipedema patients are already skeptical of doctors because they feel dismissed and gaslit by them.
And she told me, "I hate all doctors, but the only doctors that I love are Dr. Herbst and you. He's both so kind to me."
That's a very common thing I've heard from both patients and specialists. Even the standard of care mentions that lipedema patients, quote, frequently find themselves blamed for their condition, end quote. When that's the general attitude towards many doctors, I don't personally trust that patients listening to this talk would take their own doctor's advice over Dr. Herbst. After seeing this talk, it was really hard for me to take Dr. Herbst seriously anymore. Maybe her other research was well done and scientifically sound, but I wondered if that was likely in the light of this talk. At this point, I was skeptical, but I was still willing to hear her out about other things. I genuinely believed that Dr. Herbst was just trying to ease these patients' pain and discomfort in any way she knew how. And as much of a red flag as I thought a lot of these suggestions were, I wasn't ready to throw the baby out with the bathwater just yet. So I went through pretty much every video featuring Dr. Herbst that I could find just to understand the mechanism behind lipedema, even if it was just a reasonable theory. And I sure did find theories.
So instead of your body mounting an immune response against a bacteria or COVID-19, it is actually mounting a response against your own self-esteem, how you feel in your body. So if I could go back in history, the one person that I would choose to meet, at least today, would be Hippocrates. And Hippocrates said, all disease begins in the gut. I would talk about leaky gut and people would tell me there's no such thing, but now we know that's clearly wrong, that there is such a thing as leaky gut. Compartment syndrome may play a role in lipedema pathophysiology. And these fat cells become deranged and they start secreting hormones, and they're not good hormones. If you've had childhood trauma, that can lead to chronic inflammation. I think acupuncture would be great to try because I think that it does help move qi. Or you can look at IgG delayed allergy or delayed hypersensitivity reactions. And this is the test that a lot of traditional doctors don't like, but it can be useful for some people, especially if you have signs of irritable bowel syndrome. And if you find that on your IgG food allergy testing that you react to every single food, then you likely have leaky gut. There are also visceral sensitive nerves in the tissue that let you feel what's going on in the extracellular matrix. And I swear, whenever I eat ice cream, I can feel my butt growing.
It seemed with every talk I listened to, she said something weirder and crazier. Aside from some of the stranger things she said, I will say some of Dr. Herbst's theories don't seem incredibly outlandish, but these ideas are seemingly random and contradictory. It feels like she's just throwing spaghetti at the wall. Is lipedema caused by hormones, or is it compartment syndrome? But wait, if it's compartment syndrome, why does it pretty much only occur in women? And how does any of this relate to leaky gut? And if you weren't aware, leaky gut syndrome is a completely hypothetical and unproven condition. It's also another red flag for some alt-med practices. Dr. Herbst even said most other doctors don't believe it exists, and Yeah, there's a reason for that. To be clear, increased gut permeability is real. It's a symptom usually associated with things like celiac or Crohn's disease, but there is no good evidence that increased gut permeability is a disease in itself, much less that it's involved with lipedema. I had to wonder where on earth Dr. Herbst picked up all these weird things as a conventionally trained scientist. And since she is a scientist and seemingly respected in the scientific community, does she say these kinds of things in her published papers? And I can tell you now, not really. Her papers are not quite this wacky, at least not so obviously.
Chapter 9, Dr. Herbst's Research.
Whenever you hear Dr. Herbst and many of her colleagues talk about lipedema, something's always leaking.
But you see this area here? We think that's fluid in the fat tissue. And in this little dark hole here, we think that's a vessel. And that vessel has leaked out into the fat tissue here.
Leaky lymphatics, leaky vessels, leaky fluid. It's all different phrases for the same thing, which is edema. A huge piece of evidence that edema is involved, for Dr. Herbst, is the presence of lymphedema in later stages. If you'll remember, the presence of both conditions is often called lipolymphedema, but Dr. Bertsch and the ILA think that phrase isn't accurate.
Please forget the term lipolymphedema. Lipolymphedema suggests that lipedema leads to lymphedema. Lipolymphedema suggests that lipedema is the cause of lymphedema, but we do not have any scientific evidence for this popular view.
As we've already discussed, obesity-associated lymphedema is a long-proven condition, and I personally find that explanation very plausible. But Dr. Herbst believes that not only does lymphedema occur in advanced lipedema, she also thinks that edema is present even in the earliest stages, although it can't be detected. She wrote an article called Lipedema and Obesity, What's the Link?, which you can find on the website Obesity Action Coalition. This article is about 10 years old now, but I've heard her repeat a lot of these same points in recent years. She says, quote, "Female or gynoid fat under the navel, on the buttocks, hips, and thighs gives women their attractive curves." Excellent scholarly writing, Dr. Herbst. Gynoid fat increases during puberty and is smooth and soft in texture, but not all gynoid fat is the same. For example, what if you could not lose gynoid fat with strict eating and an intensive exercise regimen, and instead the fat continued to grow no matter what lifestyle changes you tried? End quote. Yeah, Dr. Herbst, what if that happened? It would certainly be a medical marvel if someone could break the laws of thermodynamics, but she goes on to insist that the swelling in lipedema is due to increased hyaluronic acid. And I can't say for sure if she's right or not, but neither can she. Dr. Herbst doesn't provide any sources in this article. Not a single one. But Obesity Action Coalition is a nonprofit, not a medical journal. I get the impression that while Dr. Herbst is giving her expert opinion here, it's still that, an opinion. I would argue that she should still provide evidence for these claims regardless, but fine, I'll give her a pass. Then, in 2020, Dr. Herbst published another article titled Lipedema is Not Just Fat on lipedema.com. She makes the same case about hyaluronic acid, but she expands on what hyaluronic acid is. It's a type of molecule in the body called a glycosaminoglycan, or GAG. Dr. Herbst then talks about how excess fluid in lipedema is bound to those GAGs in a gel around the fat cells, and that's why it can't be seen with any imaging techniques. She explains the lymph fluid in lymphedema is free-flowing within the cells, which is why you can see it flowing easily on imaging like ultrasound, for example. But if the fluid in lipedema were inside this gel, not flowing around within the body, it wouldn't be as easily detected. But the problem is this entire article, much like the last one, is chock full of speculation. You don't have to be a scientist to figure that out because, once again, she's not citing any studies to back up these major claims. Don't get me wrong, there are indeed citations in this article, but she's using these citations for general claims like describing how ultrasound is used to see lymphedema. But as far as her specific claims about fluid bound up to GAGs in a gel, there are no relevant studies to be found. For example, she writes, quote, "Lipedema, loose connective tissue, generally affects the limbs, sparing the trunk, hands, and feet. If the hands and feet of women with lipedema are not affected, then where's the fluid? We think the fluid in lipedema is bound to glycosaminoglycans in the extracellular matrix, end quote. No citation for that claim. And who is we? Dr. Herbst is the only author on this article, and she doesn't cite any studies that back her up. But I've come to find that she uses the phrase "we think" quite often. Okay, let's scroll down a little bit to a section titled Evidence that Lipedema has Fluid Bound to GAG. That sounds promising. First, she defines edema as an excess of interstitial fluid. Then she describes how there are two types of interstitial fluid. One is the free-flowing type, the kind you can see in lymphedema, and the other is the type bound up in a gel with GAGs. Sure, that's stuff we've already established. Then she says, quote, although there are not a lot of studies on GAG and lipedema, we can learn about how GAGs function in other edemas, end quote. Huh? So basically, Dr. Herbst's evidence that lipedema tissue has excess fluid bound to GAGs is that it would be technically possible. She's essentially saying, we don't have any evidence of this, but here's what it would look like if we did. I think the rest of the scientific community has a different definition of evidence, Dr. Herbst, but okay. All right, y'all. One more paper. Actually, two more papers, but in the same category. Dr. Herbst is well known for making a connection between lipedema and hypermobile Ehlers-Danlos syndrome.
We also know that women with lipedema have hypermobile joints.
If you aren't familiar, Ehlers-Danlos syndrome, or EDS, is the name for a group of genetic connective tissue disorders. The hypermobile subset of people with this syndrome have flexible joints, to the point that they hyperextend past the limits of a typical joint.
I'm demonstrating elbow hypermobility in this patient with lipedema.
There are usually more severe symptoms too, like chronic pain and dislocations. The standard of care lists obesity, lymphedema, and venous disease as comorbidities with lipedema, and I've seen just about every expert acknowledge these. But the standard of care also lists hypermobility as a comorbidity, which is something pretty unique to associates of Dr. Herbst. Right now, in her circle, hypermobile EDS is acknowledged as a comorbidity, but Dr. Herbst believes there may be a stronger genetic connection.
Hypermobile joints could be a sign that there is a connective tissue disorder in lipedema. And connective tissue, again, is everywhere in our body.
At first, I thought this was really compelling because Ehlers-Danlos affects the connective tissue, and like Dr. Herbst always emphasizes, fat is a connective tissue. There are a couple of studies that support this theory, and I do mean a couple of studies. Whenever you see literature about the link between lipedema and hypermobile EDS, they will nearly always cite one or both of these two studies. Lipedema fat and signs and symptoms of illness increase with advancing stage from 2015, or Differentiating Lipedema and Derkham's disease from 2017, both by Dr. Herbst. In the 2015 study, about 50% of the lipedema patients were hypermobile. In the 2017 study, it was about 58% of the lipedema patients, compared to about 23% of the Derkham's disease patients. But there's one really important piece of data missing from both of these studies: a control group. The 2015 study only looks at 51 lipedema patients, no healthy controls. The 2017 study looks at 160 patients with lipedema, 94 patients with Derkham's disease, which is another fat disorder, and 18 patients with both diagnoses. In this case, comparing lipedema and Derkham's disease is slightly better than the 2015 study, but not really, because a true control group should have neither condition. And I should also point out that these two studies are not about hypermobility. Those statistics are basically just footnotes that are not explored any further. And how did Dr. Herbst determine hypermobility? She used the Baton scoring system, because just like lipedema, hypermobile EDS is a purely clinical diagnosis. There's no genetic test like with some other types of EDS. So clinicians will often screen patients using this Baton scoring system, which assesses the hyperextension of certain joints. There are 9 possible points you can score, and 5 out of 9 is considered hypermobile. And this is the same threshold that Dr. Herbst used. One problem with the Baton scale, though, is that hypermobility also might just be really common. A lot of people are hypermobile, and it's actually hard to tell how common it is. I've seen studies show a prevalence of anywhere between 2% to 57% of the population have general joint hypermobility, and other studies show percentages everywhere in between. There is more scholarly debate about the Baton scale, and I actually covered that in another video that I'll link below. I'm not saying we should throw out the Baton scale. I don't think anyone is arguing that, because I do think it's useful, but it's troublesome to me that the Baton scale is the only metric used in these two studies. A high Baton score itself is not usually considered sufficient to diagnose EDS. Usually, a clinician will look for other symptoms and also rule out other potential causes for those hypermobilities. You know, differential diagnosis. Dr. Herbst does say in these papers that the high scores indicate possible hypermobile EDS, but there have been no formal attempts to confirm this. I should also point out that standard of care doesn't say hypermobile EDS is a comorbidity. It says hypermobility in general is, and it uses these studies as evidence. But I would argue that even that is a problem. Maybe it's true that lipedema patients are more hypermobile than average, but these studies also didn't prove that. But Dr. Herbst and her associates used these studies to make the case that lipedema is a connective tissue disorder because of this possible link to EDS. To me, this claim seems premature at best, but lipedema literature, especially in the US, is littered with it. And on top of EDS, Dr. Herbst and several more people in her sphere promote that there are more comorbid conditions of lipedema.
I'm going to be giving a brief overview of hypermobile Ehlers-Danlos, mast cell, and POTS. I'm noticing more awareness of this group of related inherited syndromes that overlap with lipedema symptoms and comorbidities.
Would you like to guess how much evidence supports these claims? I'll tell you this, there's even less evidence than there is for hypermobile EDS. I've just wondered for quite a while what made Dr. Herbst consider testing for hypermobility in the first place. Then I found out she herself has hypermobile EDS.
And I don't know if you know this, but I have hypermobile EDS and I wear compression.
I did not know that.
Yes, I do. And the funny thing, I was diagnosed in 2016. And I was going through the Baton criteria for all of my patients, and I would do everything and say, this is how you do this is how you do that. But I wasn't thinking that I have hypermobility.
I'm not sure what to make of that coincidence, but there it is. I think it would take me a lifetime to unravel the tapestry that is Dr. Herbst. That clip was from a podcast called the Bendy Bodies podcast, which is obviously focused on hypermobility. And this podcast appearance was very telling. It seems Dr. Herbst believes that the possible connection between lipedema and EDS also explains why lipedema progresses.
When you have connective tissue mutations, you have a loss of elasticity. So the tissue doesn't bounce back like a rubber band. And so fat grows and the body goes, okay, I'll be compliant. I'll handle that. If it doesn't have that skin, that tension in the skin, it's just going to keep growing and growing and growing and growing and growing. And then you can't lose it.
Yet another theory. Keeping in mind that I'm not an expert, I think that theory sounds ridiculous. Skin laxity allows fat to just keep growing forever? Fat is energy storage, so where's the energy coming from? And why don't other people with EDS also have the same problem? Stretchy, lax skin is a problem for many types of EDS. If skin laxity is the problem, why don't they have the same symptoms as lipedema patients? At this point, I am sick and tired of saying source, because once again, she gives none. I mean, this is a podcast, so I don't blame her for not referencing studies for everything she says. It would be really clumsy in this format, but I do think it's notable that the only studies she does reference are the 2017 one that I've already mentioned, authored by her, as well as another study of hers that's yet to be published.
Between the two, it's just nobody's found it yet. And not a lot of other people are looking at it, which, I mean, we've published now 3 different papers where we state that about 60% of women have this, and then the latest is not published for 75%. Why aren't other people looking at it?
Oh, and she does reference this.
I have a friend in Spain, and he says it's about 80% in his population.
Wonderful citation, Dr. Herbst. I'll go look that up right now. Dr. Herbst's friend. And by the way, I was not able to find any study that showed that 80% figure. Does it not also seem strange that as the studies go on, the percentage of hypermobility just keeps going up? And even if it were true that 80% of lipedema patients have hypermobile EDS, that doesn't mean EDS causes progressive fat growth. I think it's already questionable whether the correlation is that high, but taking that one piece of data and extrapolating it the way that Dr. Herbst does seems wild to me. My main takeaway with all of these little rabbit trails into Dr. Herbst's research is that she often makes major claims with little to no reliable evidence to back her up. Those 2 studies into hypermobility are certainly a good starting point, but they lack sufficient evidence for the types of claims she makes elsewhere. But Dr. Herbst states things like, EDS is a comorbidity. We think EDS is a comorbidity, and we think lipedema is a lymphatic disorder, and we think lipedema does occur in the abdomen, as if these are just scientifically proven facts, but that's just not true. All of those papers seemed pretty suspicious to me, although I'm not an expert. But even as a layman, I do understand how good studies are usually done. Dr. Herbst has also published many, many other papers in different areas of research, and I can't vouch for how well done those are because I haven't dedicated months to checking them. She very well could be an excellent researcher elsewhere, and these less reliable papers could be the exception to the rule. But even if that were the case, there shouldn't be an exception to good science. Even though I have issues with these papers, I couldn't help but notice that it seems Dr. Herbst is a lot freer with her words in the YouTube videos than she is in scientific publications.
And I swear, whenever I eat ice cream, I can feel my butt growing.
Now that's just my opinion. Clearly Dr. Herbst knows her words are online forever, and she would very likely stand by them no matter what. But personally, I find it interesting that there's a huge difference between the Dr. Herbst of scholarship and the Dr. Herbst of the lipedema community. I think Dr. Herbst is a lot more willing to make unfounded, alt-med types of claims when she's surrounded by like-minded peers and patients. You probably won't find her talking about traditional Chinese medicine and ice cream butt in a medical journal. Of course, she is a widely respected scientist, and she knows well enough to couch a lot of her more bizarre statements in things like, this claim isn't proven yet, or this treatment may work, but we don't know for sure. But with that in mind, I found it fascinating that Dr. Herbst was saying a lot of these kooky things on channels run by a company called LymphaPress. LymphaPress produces compression pump devices primarily for lymphedema and venous disease, but they've also expanded their marketing to lipedema patients. These pumps are wearable devices that inflate to create pressure similar to MLD, so patients can do this at home. Like a lot of companies, LymphaPress has their own YouTube channel called LymphaPress Global, but they also have another channel called LymphaPress USA, and another channel called the Lipedema channel. And they also have a podcast called the LymphaPress Podcast. Very creative titles, I know. These various channels do discuss the products, but they also feature a lot of educational talks, like those by Dr. Herbst, if you use the term educational loosely. Now may I introduce you to Brenda Viola, former VP of LymphaPress's Marketing and Communications Department, and current professional yes woman. Brenda is now president of her own communications company, but it seems she's still host for hire on the majority of LymphaPress's videos. Watching these videos is a very bizarre experience because there definitely is a vibe of education and care, but these videos give the disclaimer that they're not medical advice. Obviously, these are still, ads for compression pumps. Marketing medical products is weird no matter how you do it, but it is sometimes necessary, especially in the US because of our for-profit healthcare system. So I can't fault them for that, but it's just so funny to watch Brenda interview an expert or a patient and go, yes, active listening. And that's why we recommend this wonderful LymphaPress product.
We had one person ask about pain, and we've seen patients have reduced pain, increased mobility, and even reduction. Could you speak to the efficacy of the LymphaPress pneumatic compression pump before I get into the other questions?
Dr. Herbst is featured heavily on the LymphaPress channels, but she isn't the only expert they've featured. There was another name that kept popping up time and time again during my research. Let's talk about Linda Ann Kahn.
Chapter 10, Linda Ann Kahn.
Linda Ann Kahn is a lymphedema therapist, a massage therapist, an aromatherapist, a beauty therapist, and an integrative health coach. If it wasn't painfully obvious already, I'm a big ol' skeptic. So when I hear integrative health, a little red flag pops up in my head. Unfortunately, although concepts like integrative or holistic medicine sound great, those terms are often co-opted by non-scientific practices, so I'm always a little leery when I hear those phrases. But the big red flag is integrative health coach, because you don't need any kind of certification to call yourself a coach, even if the word health is in the title. This is not a regulated field. And that became very clear to me when I heard Linda Ann speak.
What you're thinking goes into all the cells in your body and translates to that, so we want to be very positive all the time. But 70% of your immune system is in your gut. Get yourself a dog, let the dog lick you, and go outside and play in the dirt. Or there's been adverse childhood events, but just the trauma of lipedema can create many, many problems in the tissues. There is a connection between the heart and the brain and the vagus nerve, and that all relates to dopamines and lipedema and also mast cell activation. We're going to look how trauma is stored in this extracellular matrix. My teacher, John Barnes, has a lot to say about this, and when you have myofascial release sessions, that you can actually see and witness this release of the trauma that has been in the tissue for sometimes for years and years and years. Stress and emotions from your past, which are stuck in your joints, tissues, organs, and fascia, and then the vagus nerve won't function properly. And then you start to have gut issues, brain fog, emotions, and an increased heart rate. Some of the patients have POTS, which is postural orthostatic tachycardia syndrome, so it's all tied in. And of course, I love to laugh. And when you laugh, you lift your mood, you're boosting your immune system, you're helping your lymphatic system to move. Well, it's interesting that you're asking that. One of my heroes, Dr. Alexandra Amata, who's from Brazil, just did a study showing the connection of ADHD and lipedema. Many of the patients have problems with the veins, so aromatherapy can help with a lot of that. So enzymes can be fantastic. And usually I start people off slowly because they really can have almost like a toxic effect as they start to detox. So you start off with one a day, and then you go to 2 a day, and then you add the third one.
Okay, so we always put this disclaimer here, although you are quite proficient and you have a lot of letters after your name. We are not offering any medical advice.
You will find Linda Ann in all kinds of lipedema spaces. She's in an episode of what LymphaPress calls their leadership series, as well as a video on their lipedema channel. Yep, this company that produces medical devices wants the expert opinion of Linda Ann Kahn. This is part of the reason I called Brenda Viola professional yes woman earlier. She sits there as the host on these videos listening to the most whack nonsense you've ever heard in your life, and she's still able to smile and nod. It's a level of emotional control I truly envy. There's a lot to unpack in these videos, and I simply do not have time to unpack it all. I mean, you've seen the runtime of this video, but I do want to hit on just a few key points so you can understand just how wacky all of this is. Linda Ann talks so much about emotional trauma. She blames pretty much everything on trauma and stress. The theory that emotional trauma is stored in the body has run absolutely rampant in pop psychology nowadays, but you just need to know that theory is not accepted in the wider psychology community. She relies heavily on Stephen Porges' polyvagal theory.
And the polyvagal theory, there is a book by Deb Dana, based on the work of Dr. Stephen Porges, Porges,
which has been described by a consensus of other experts as untenable. There's not a lot of evidence to support it and plenty of evidence to refute it. I know some people will disagree about that, and I do think it's a nuanced topic, but not this nuanced. At the very least, the idea that any type of massage could effectively release emotional trauma is, I'm sorry, just nonsense. Linda Ann promotes a metric ton of questionable practices, and let me emphasize again that her only legitimate medical certification is as a lymphatic massage therapist. She is not a doctor, and she's certainly not a mental health professional. And a note about aromatherapy: there is evidence that inhaling essential oils can be calming and help with things like anxiety and nausea. But the things Linda Ann claims are well outside the scope of that evidence. Her website advises aromatherapy for scarring, autoimmune disorders, and undefined detoxification, which is just another red flag. If you have a functioning liver and kidneys and you haven't been acutely poisoned, you don't need to detox. This is, again, often just a concept used to sell you things you don't need. And shock and surprise, Linda Ann does indeed sell essential oils. If you visit her website, lymphatictherapyservices.com, you can purchase, amongst other things, a bottle of detox oil, which consists of juniper berry, pine, spike lavender, geranium, and black pepper, and this can be yours for only $35.25 US. That price will get you 0.34 ounces, or approximately 2 teaspoons of oil. Or if you prefer, you can get a clinical aromatherapy treatment by Linda Ann herself. It's only $175 for one 80-minute session. A steal! As far as I'm concerned, Linda Ann Kahn is just a walking red flag. She makes so many strong claims with little to no scientific backing. One of the worst things she believes, in my opinion, is that things like emotional trauma can cause pain in lipedema.
Or there's been adverse childhood events, but just the trauma of lipedema can create many, many problems in the tissues.
You could be a well-adjusted, mentally healthy person with this chronic pain condition, and Linda Ann could waltz in to say you have some unresolved emotional trauma causing your symptoms. I'm afraid a lot of these people are not getting the help they actually need, and they could feel much worse after being told something like that. Alright, so that's Linda Ann Kahn, but why is she on LymphaPress's YouTube channels? Why is she interested in lipedema? And why is she considered an expert in this field? So the thing about Linda Ann Kahn is that she also has lipedema.
I'm so passionate about treating lipedema is because I have lipedema. And I know all the struggles that I had when I was a teenager and as I got older, and all the struggles that I had, and I would look at the other girls' ankles and look at their legs, and in those days we wore high heels with straps around the ankle, not good for someone with lipedema. And I think, oh my God, look at those ankles. I always wanted that, and my legs were just straight.
She was diagnosed with stage 1 lipedema in 1991 by her lymphedema therapy teacher.
Graduating as a lymphedema therapist, Hildegard said to me, look, you have lipedema, because we all, we were on the table working with each other. And I said, but I don't look like the pictures you've been showing us. Well, it was because I had stage 1.
Now, I was not under the impression that a lymphedema therapy teacher was qualified to diagnose people, but sure, she says she has a diagnosis, so I'm going to grant her that. Interesting, however, that all of her associates in the lipedema field claim that it's usually a progressive disease. It gets worse over time. But Linda Ann has never progressed past stage 1. She's around 68 years old now and claims that she actually lost weight with exercise and good nutrition. Fascinating. Sounds very similar to Dr. Bertsch's claims about his patients, doesn't it? But as you've already heard, Linda Ann has some more unconventional treatment methods as well. She offers all sorts of services at her clinic, and I would be willing to bet she attributes her remaining at stage 1 to a lot of those practices on top of nutrition and exercise. Like I said, Linda Ann is certified in lymphatic massage, and she's an integrative health coach, but she is not a doctor. But during her talk on the Lipedema channel, she claims that even though she cannot diagnose lipedema officially, she's able to diagnose it.
So I'm not a physician, but I can diagnose lipedema, DOCMs. I mean, my hands just know. I do a full, palpation everywhere to see what's going on. And I always say, I'm not a doctor and I can't diagnose. However, I know exactly what they have. And I have many, many patients coming who looked on the website, they've Googled heavy legs, they think they might have it, and then I will palpate and I will tell them.
Following in her teacher's footsteps, I see. I just have to wonder if those people always follow through with a professional diagnosis, or if they just take her word for it. Because with all due respect, she could very well be wrong. It is with great sadness that I tell you, Dr. Herbst works very closely with Linda Ann Kahn. She references Linda Ann all the time, tells patients to look into her therapy, and they've even written a book together along with a few other people. It's titled Lymphedema and Lipedema Nutrition Guide: Foods, Vitamins, Minerals, and Supplements. It's no surprise that Dr. Herbst referred to Linda Ann in that supplements talk from 2016.
Just from squeezing a lemon and maybe taking a little bit of that peel and putting it into your water. I know if you go see Linda Ann Kahn in her clinic, she's got lemon water with cucumber.
Once again, there's nothing wrong with taking supplements or focusing on nutrition, but there are no studies on the effects of supplements on lipedema. How are you publishing a book on that? And would you agree that we might take anything with Linda Ann's name on it with a grain of salt at the very least? Well, how would you feel if I told you her name is listed second on the US standard of care? Yep, that's right. She is not a doctor. She is a massage therapist and an aromatherapist. But as far as this committee, and I guess the publishers of the journal Phlebology are concerned, she's an expert. It's so funny. You can find a list of the standard of care committee members and their credentials at lipedema.com, and it calls Linda Ann a lymphatic therapist, of course, but it also calls her a frequent speaker on lipedema. And I'm like, well, that is a true statement. She said some absolute nonsense about lipedema pretty frequently. I will admit to you, at this stage in my research, I was starting to feel a little bit insane. I've been telling my long-suffering best friend about my research for the months that I've been looking into it. Sorry. And I do remember sending a text at one point that said, is this condition even real? And worry not, I have come back around to believing that lipedema is real. I mean, even Dr. Bertsch and the ILA think it's real, and their views are in extreme contrast with Dr. Herbst and her colleagues. But isn't that kind of sad? There seems to be so much bad science here that I briefly considered that this condition was just made up whole cloth. Effectively, Dr. Herbst and her colleagues did the opposite of what they intended. There are several medical doctors on the standard of care committee, but then you've got people like Linda Ann, other massage therapists, a yoga instructor, and a couple of lipedema patients with no other credentials. Sure, getting input from patients is great, but just because I have an illness doesn't make me an expert on it, and it certainly doesn't mean that I should take part in writing the official treatment guidelines. I mean, the standard of care says it's a consensus document. They measured consensus as at least 75% agreement from the committee. But did a patient advocate get just as much of a vote as a doctor? Did Linda Ann get just as much of a vote as a doctor? This may be a consensus document, but I'm here to tell you not all opinions in it carry the same weight. I'm pretty sure my bias is clear at this point, but I was a little more open-minded until I discovered Linda Ann Kahn, especially when I found out how closely connected she was to Dr. Herbst. I didn't even realize all the red flags with Dr. Herbst until I saw what kind of people she worked with. When I found out Linda Ann Kahn's huge role in the standard of care and in the lipedema community, my mind closed like a steel trap. I had to wonder how someone like Linda Ann, who promotes all kinds of unfounded practices, could be featured on LymphaPress in the first place. And even Dr. Herbst, considering some of the weird things she said. As a host, Brenda Viola kind of has to be a yes woman, but what about the rest of the company? Don't these videos go through some kind of vetting process? Well, I have been keeping a very important piece of information from you. Since January 2022, Dr. Herbst has been the Chief Medical Officer of LymphaPress. At first I didn't even realize this because it's not listed on her LinkedIn, but the company has a press release about it, and she does disclose this in videos by LymphaPress.
And I'm going to talk about things you may not have known about lipedema. And my disclosure is I am the medical director for LymphaPress.
Clearly, Dr. Herbst has huge pull with LymphaPress. Maybe it was because of her influence that they were open to hosting Linda Ann. And if I may put my tinfoil hat on, I kind of wonder if LymphaPress likes both of them so much because their beliefs are conducive to selling more products.
Chapter 11, What is there to gain?
Remember, Dr. Bertsch and the ILA argue that there's no need for MLD and no need for compression pumps because there's no fluid in lipedema. The massage might feel nice, but there's been no evidence that these things actually improve symptoms in pure lipedema. All this time, I've wondered why Dr. Herbst and her colleagues have been fighting so hard to prove there is edema. To me, it seems like they're beginning with their conclusion and they're working backwards to try to show it's true. All of Dr. Herbst's talks seem to say, we know that there is fluid and we know the fluid causes fat growth, but we just haven't been able to prove it yet.
The small saphenous vein that's on the back of the leg wraps around the lateral malleolus. And if you have increased pressure in this vein, it pushes fluid down around that lateral malleolus. Well, fluid makes fat grow. Is that malleolar fat pad that we see on the outside of the foot due to venous disease and lipedema? That's something that we need to verify and find out.
So my question, having watched Dr. Herbst and her colleagues fight tooth and nail to prove there is edema, is why? Well, think about it this way. If there is no fluid edema involved in lipedema, then there would be no need to advertise expensive compression pumps to lipedema patients. There would be no need to refer patients to MLD therapists like Linda Ann. And there would be no reason for insurance companies to cover the cost of these treatments. Finding out Dr. Herbst is LymphaPress's chief medical officer sure did paint a picture for me. I can't say there's anything nefarious going on here, but in my opinion, I'd call that a suspicious coincidence. I know, I sound like a conspiracy theorist. And I should say, Dr. Herbst and the Standard of Care Committee aren't the only ones claiming that lymphatic dysfunction could lead to lipedema. You may remember, way back at the beginning of this video, I said that there has been research into a possible biomarker, something that could potentially lead to a blood test for lipedema. And this research also suggests a link to lymphatic disorders. The best evidence is found in a paper called Platelet Factor 4 is a biomarker for lymphatic promoted disorders. There's a very good panel discussion you can find on YouTube called MOH Talks Lipedema Diagnosis and Treatment, and it features several lipedema experts. One of them is Dr. Stanley Roxon, an American lymphatic specialist and one of the co-authors of that biomarker study. He and his co-authors have discovered an elevated protein level in the blood that could potentially tie lipedema and lymphatic disorders together and distinguish them from obesity. This protein is called platelet factor 4 or PF4. Now, that's a really compelling finding, but this is a panel discussion and the three other panelists have some issues with the study. One of those panelists is Dr. Bertsch, and the other two are Dr. Borman from Turkey and Dr. Schuba from Poland. All three of these panelists expressed concerns about the reliability of the study, especially since it had a very small population of 50 people. The study included 37 lymphedema patients, 11 lymphovascular disease patients, 15 lipedema patients, and only 12 controls with none of those conditions. You know what? I'm glad there were controls at least. The bar is low. As the other panelists point out, these sample sizes are very small. There are only 12 controls and only 7 of them are obese, which is a problem since there's a huge overlap between lipedema, lymphedema, and obesity.
Because there's a significant overlap between obesity and lipedema. Majority of lipedema patients are in fact obese, and in clinic it's very difficult to sometimes it's very difficult to distinguish if it's pure obesity or this obesity with lymphedema, because even purely obese people with fat legs will have pain in the legs, for instance, and some other problems.
Even Dr. Roxon agrees there should be more robust studies done to replicate these findings, because it's plausible that some of the lipedema patients in this study could be suffering with obesity-associated lymphedema, since 12 out of the 15 lipedema patients were in fact obese. One of the other major problems with this study is how it draws its conclusions. The study says, quote, "Finally, our results support the prevailing hypothesis that in lipedema, lymphatic dysfunction plays a role in the pathogenesis of the disease," end quote. But looking at this data and calling lymphatic dysfunction the pathogenesis or the origin of lipedema is skipping so many steps. This study didn't prove that lipedema comes from lymphatic dysfunction. I'm willing to accept lymphatic dysfunction causes elevated PF4. That's not the issue. From what I can tell, all the elevated PF4 shows is that lymphatic dysfunction is present. It's a correlation, but it doesn't show causation. Like I said, 12 of the 15 lipedema patients in the study were obese. Why are they not considering that factor when obesity-associated lymphedema is so common? That conclusion is not so clear-cut. So then tell me why. The title of Dr. Roxon's presentation in this panel discussion was, "Now we know lipedema is a lymphatic disease." That seems awfully premature after one small study, Dr. Roxon. Dr. Bertsch also made a presentation on this panel, and he made this comment.
Thanks again. And when I just read the title of Dr. Roxon's talk, "Now we know lipedema is a lymphatic disease," I thought I would have to change the title of my lecture. "Now we know lipedema is not a lymphatic disease."
Oh, he's so sassy. Now, with that background, I want to point out something interesting I noticed. When Dr. Schuba points out some flaws in this study, Dr. Roxon gives this response.
Do you think that making this control group of really obese people with BMI of 40 or more would be helpful because they also have some kind of inflammation in their fatty tissue. So that's my concern and question.
Well, I agree, Andre. I have lots of concerns and questions as well, because this was really a pilot study that was meant to hybridize mouse work with human. I think it's an interesting lead, and we need a much larger study and with more well-defined subgroups. I share absolutely everything that you're saying. In a pragmatic context, what we face in the United States, and we're outliers for most of the world in that we don't have good medical support beyond commercial third-party payers. What becomes a pragmatic question for these patients, and in my lipedema patient group, the majority of them, I would say, have constitutional obesity as well as the lipedema presentation. The third-party payers are extraordinarily reluctant to pay for cosmetic liposuction. So therefore, those that support tumescent liposuction for lipedema want some evidence that this is truly a disease that they're treating. And this is where I think the biomarker approach would be very useful, is to say this is constitutional obesity plus.
I think this is a nuanced topic, especially since we do have a for-profit healthcare model in the US. But I just can't ignore the fact that when Dr. Roxon is pressed about the flaws in his study, one of his main defenses is the need for insurance to cover liposuction. I didn't edit anything between that question and response. That was really his immediate answer. And sure, this is an understandable argument. Liposuction is generally considered cosmetic, but it can be a treatment for lipedema. Insurance companies don't always see it as a medical necessity and refuse to cover it. A blood test, a hard figure that proves a patient has lipedema and proves it's a lymphatic disorder, would be revolutionary for getting a lot of treatment measures covered. Not just liposuction, but MLD, compression pumps, compression garments. I just find it fascinating that one of Dr. Roxon's first defenses is liposuction. I couldn't tell you for certain if Dr. Roxon has any motives here, but I can tell you he's very active with an organization called the Lipedema Project, which was co-founded by a plastic surgeon, Dr. Mark L. Smith, who performs liposuction. Putting my tinfoil hat on again, but it is an interesting coincidence. Dr. Roxon isn't the only lipedema expert working to advance liposuction treatment. Dr. Herbst herself is involved with 2 plastic surgery practices. Since 2021, she's been the medical and research director for Total Lipedema Care, and since 2024, she's been the head of research and director of diagnostic and preventative medicine for the Roxbury Institute. If you're familiar with my channel, you've likely heard of the Roxbury Institute, which is led by Dr. David Amron. When the influencer Anna O'Brien decided to see Dr. Amron for her lipedema surgery and began featuring him in her content, I noticed he used a lot of what I'll call Herbst-isms.
It's crucial that surgery is done on her, otherwise it's going to continue to progress and more fibrosis and more problems with things. Lipedema is a systemic condition. It's not only just in the fat, it's occurring kind of throughout the body.
I was not at all surprised to find that Dr. Herbst was connected to this practice. At this point, I was already very skeptical of Dr. Herbst, but when I did a deep dive of Dr. Amron, I discovered a whole new layer of controversy.
Chapter 12, Liposuction.
Dr. Amron's Roxbury Institute actually performs all kinds of plastic surgeries. Liposuction for lipedema is only one of them. It's under the Advanced Lipedema Treatment Program. Dr. Amron has been pushing the ALT program hard over the past several years. If you watch my channel, you already know the issues I have with Dr. Amron. I have a couple of videos exploring his work as a celebrity plastic surgeon in Beverly Hills, and his work with lipedema. And the fact that he's a celebrity plastic surgeon doesn't make him a bad person or call his practice into question. But the fact that he pushes so many problematic ideas about lipedema and fat in general does make me suspicious.
Lipedema is a systemic condition. It's not only just in the fat, it's occurring kind of throughout the body because it's a connective tissue weakness. That's really the primary thing going on, looseness of connective tissue. You've got leaky lymphatics, fragile capillaries, hypermobility, Ehlers-Danlos, which is a connective tissue disease, leaky gut syndrome in a lot of patients. And that's another thing. Many times patients with leaky gut syndrome have been misdiagnosed because it's really kind of part of lipedema. Eventually, it will begin to slow your metabolism down because this fat is not only responding to hormones, it's producing estrogen and other hormones that progressively makes it harder and harder to lose weight. So you're about stage 2, she just begins to lose the whole battle with it, and she can find herself starving, eating very, very little, and she's still putting on weight, right?
There it is again. leaky gut, hypermobile EDS, the idea that you can grow fat even if you're starving. Now, I will admit to breadcrumbing my regular audience a little bit with Dr. Amron. I've discussed my issues with him at length while largely neglecting who I think is the real culprit behind his questionable ideas, Dr. Herbst, because without her input, I doubt he would have come to any of these conclusions himself. Dr. Amron is a dermatologic surgeon. He did go through med school, but he readily admits that he never heard about lipedema during that time.
I was highlighted doing a lot of calf and ankle liposuction patients. It aired in Europe, and all these patients from Europe started coming over from England and France saying, Dr. Amron, I have lipedema. I want you to do my legs and make them look beautiful. And I'm thinking, lipedema? I'd never really heard of this condition. And started realizing all these patients that I was doing really had lipedema for over 12 years before. And that's kind of what got me into it.
Dr. Amron has been called the pioneer of lipedema surgery in the US. And I don't really have a problem with that statement. Liposuction is recognized as a valid treatment option by most experts, and it seems a lot of his patients are happy with his work. I mean, there's a reason he's also popular with celebrities for cosmetic surgery. I don't think Dr. Amron is a bad surgeon. I just believe he doesn't have any evidence to support a lot of the things he says about lipedema, because he's just parroting what Dr. Herbst says, and we've already gone over her cutting-edge research. My other issue with Dr. Amron, besides the possible misinformation, is his method of advertising. I think we've established the fact that the American healthcare system is a hellscape, but in my opinion, there's a huge difference between advertising your medical practice and whatever this is. Yep, those are TikToks Dr. Amron has made with influencers that he's operated on. Not just Anna O'Brien, but another popular TikTok creator named Allison Jacobs. He's actually operated on several influencers, and he's featured some of them in his YouTube series called Lippy Logic. And I think beyond the fact that these videos are cringy, they're also worrisome. I said before that if my doctor recommended eating apricot seeds, I'd be out the door. But if my doctor did TikToks with influencers, I wouldn't even enter the building. At first, when I found out Anna was having surgery with Dr. Amron, I said I thought she was in good hands. Dr. Amron seemed to be a respected surgeon and highly regarded by his patients. But when he started making those TikToks and other videos with Anna, I started getting really skeeved out. He seemed not only comfortable with operating on someone of her size and telling her this was her only hope, but he also seemed very comfortable featuring her and being featured on social media. As it turns out, Dr. Amron is no stranger to media exposure. He's a lot like Dr. Herbst in that way. Calling him a celebrity plastic surgeon is true in two ways. He performs surgery on celebrities, but he's also basically a celebrity himself. He's been featured on multiple documentaries, daytime television shows, and even one Netflix reality show that focused on his life as well as some other plastic surgeons.
My name is Dr. David Amron. I'm a Beverly Hills cosmetic surgeon. I specialize in liposuction surgery for 20 years. I'm competitive. I want to be the best at what I do with things. I think that we're all that way with our work.
But that doesn't mean he's a bad doctor. I just find some of the things he says in these appearances to be problematic. Even before he started operating on lipedema patients, Dr. Amron was on record saying that he wouldn't even do liposuction on patients who could reduce their fat with diet and exercise. I encourage you to watch Louis Theroux's Under the Knife to see what I mean. The clip that I tried to use in my last video, it got copyright struck, and technically I could dispute that because it does fall under fair use, but I don't feel like dealing with all of that, so I'm just gonna describe it to you. I have another quote. He says, "My whole thing is about proportion and balance." And then he says, if I feel someone can achieve the results that I can achieve with diet and exercise, I don't do them. So basically he's saying, hey, Louis, actually, you could work out and you could eat well. You will never achieve the results that I have given you with liposuction. That's just so silly. And not only is it silly, it's the exact same thing that Dr. Amron says now about his lipedema patients. Now listen, once again, I can't make any bold claims about whether Dr. Amron or any of these doctors are doing anything nefarious, but in my opinion, it's hard to not view this whole thing as kind of a ploy to get more patients. These are some very unsupported claims. I mean, not to get morbid, but I think a lot of us have at least seen pictures of victims of starvation. They do not have this stubborn fat problem. That, combined with his connection to influencers who have these huge audiences of, frankly, potential clients, well, painted a picture, I'll just say again. Like I said, I was already suspicious of Dr. Herbst, but when I uncovered these issues with Dr. Amron, it really shook my mental image of her. It was the Linda Ann Kahn effect all over again. But even worse, because at least Linda Ann is also a lipedema patient, so she probably practices what she preaches. For me personally, in my opinion, I wouldn't trust someone like Dr. Amron to be my doctor. And let's not forget about Dr. Herbst's other affiliation, Total Lipedema Care, which is run by Dr. Jamie Schwartz. Dr. Schwartz also began as a typical plastic surgeon. Just like Dr. Amron, his trajectory changed once he discovered lipedema and Dr. Herbst.
How did you get into the specialty of this?
We say liposuction does not treat obesity, but we found that if I can liposuction the whole midsection for people that are on their weight loss journey, it actually can jumpstart a lot of things. So we were going towards that. We were seeing a lot of people that were losing 50, 100 more pounds, but yet the same thing. You didn't really notice it. It was the whole upper body was getting smaller. Some people's legs weren't. And so as we started operating and doing more legs, you started noticing that it really was different fat. It wasn't the same. I can't explain it overall, but it was a different patient population also than someone that was just getting gastric bypass. And so that's kind of how a lot of this started.
And just like Dr. Amron, he advertises with social media influencers. That clip I just showed was with a patient of his. He performed several liposuction procedures for this influencer named Kara Cruz, or Pale Ginger Pear, and she promotes him frequently on her social media. I can't prove that these influencers are getting financial assistance for their surgeries in exchange for exposure, but I don't think it would be outlandish to assume that could be happening. I think there's also a mutually beneficial relationship between these surgeons and people like Dr. Herbst. I have to mention, Dr. Schwartz was one of 4 plastic surgeons who authored the Standard of Care. The Standard of Care, which insists that lipedema reduction surgery is currently the only available technique for removing abnormal lipedema tissue. It is also the only treatment that slows progression of lipedema. Interesting. Even though Dr. Amron wasn't on the Standard of Care, Dr. Herbst now has a diagnostic center with his Roxbury Institute.
So excited and proud to have Dr. Herbst join forces with me. And it's truly great for lipedema and the lipedema community, and we're going to do great things together.
Yes, we are. I cannot wait to collaborate with my patients again at the Roxbury Institute.
I think it's a reasonable assumption that she would refer her lipedema patients to Dr. Amron for liposuction, another mutually beneficial relationship. And there's not necessarily anything wrong with that on a surface level, right? Of course, the diagnostic center would refer people to get treatment, and you should expect to get paid for the work you do. I mean, I expect to make money off of this video. I don't have a problem with people making money, but I do have a problem with people spreading potential misinformation, especially when that misinformation could lead to people getting unnecessary and expensive treatments. Remember that Bendy Bodies podcast? Dr. Herbst mentions her diagnostic center does not accept insurance. It's self-pay only.
This is a lot to try to cover in these short visits that a lot of people are experiencing.
Mm-hmm. Yeah, I do. I'm in a cash-based practice because of that. I barely get done in an hour.
I sure wonder why.
There's a high performance pump in there that sucks air out from around you and then it puts it back in. And it sucks it out, it puts it back in.
If you pay really, really close attention to Anna's video and TikTok, you can see on the base of that CVAC chair, there is a black plaque with white, bold lettering that says prototype.
And then I am heavily into the genetics. We use a direct-to-consumer company, so we are empowering women with lipedema to go through their own genomes.
Or you can look at IgG delayed allergy or delayed hypersensitivity reactions. And this is the test that a lot of traditional doctors don't like.
I know Dr. Amron's practice tends to get insurance to cover liposuction, but this is typically very difficult. To be honest, a lot of us who watch Glitter and Lasers thought her assessment through Dr. Amron's practice was a little strange to say the least.
We were able to get some support from Dr. Amron's team and to actually meet with an occupational therapist who specializes in basically writing to insurance the ways that your mobility and quality of life has been affected by lipedema.
So the purpose is so we can see if you have any functional limitations because of the lipedema. So we're going to be looking at things like your range of motion, your strength, cardiovascular fitness. I wanted to ask you, have you been doing any kind of conservative therapy? I'm sure you have conservative therapy as far as for your lymphatics, MLD, the pump, anything like that.
I don't have the pump. So because I was losing weight, I wore full compression for a while, but then I basically sized out of it.
Okay.
And then I had a problem finding gear that actually fit.
Okay.
So it was on my list to purchase new gear or get custom gear made.
Looks like you've done all of those things. Oh gosh, you've like done everything. You've done everything.
What do you mean?
Meaning like you've done every conservative measure, like you've done the dry brushing, the self MLD, don't have the pump yet, but you're working on that. You've been wearing compression, you've been exercising, you've been doing the diet, like you've done everything right.
You're doing awesome. You're almost in a minute. Amazing. This is the one thing I feel like I can do. Yeah. Because it doesn't really hit me until a mile in that I hurt real bad.
Again, I can't make any claims, but it seems like this occupational therapist was just kind of taking Anna's word for everything, and they weren't even in the same room together. Getting insurance to cover anything can be difficult, especially for a rare condition like lipedema. But it's also difficult because there isn't a lot of evidence to support the efficacy of liposuction. So why do all of these experts believe it's so necessary? We've already discussed Dr. Herbst and her colleagues' opinion that lipedema fat can continue to grow no matter how much a patient diets and exercises. And that's a major reason why they recommend liposuction. Dr. Amron perpetuates the idea that lipedema is continually progressive, but his surgery acts as a reset. He also asserts that the reason lipedema fat continues to grow is because it severely lowers metabolism.
Patients will typically have lipedema in their extremities, their arms and their legs, and it will begin to progress. When they move about stage 2 or stage 3, they'll then begin to metabolically be handicapped and begin to put on weight in their abdominal area or torso area in areas that they never really had problems with it before. So actually what happens before the surgery, when they try to lose weight, they're just not really able to lose weight. But after the lipedema surgery is when you've removed all that hormonally active fat, people's metabolism begins to reset itself again.
But I'm prepared to say, based on my research, that simply isn't true. Dr. Schuba, the Polish doctor who was on that panel discussion from earlier, has been involved in several studies trying to measure lipedema patients' metabolisms. If you're into counting calories, you may know there are calculators online that can estimate your metabolic rate based on your stats, but these calculations are merely estimates. Thankfully, there is a much more accurate measurement, which is called indirect calorimetry. You breathe into this machine and it calculates your resting metabolic rate based on oxygen consumption and carbon dioxide production. Dr. Schuba and his colleagues conducted a study that compared this very reliable indirect calorimetry to those BMR calculators. And unfortunately, they found that those calculators were less than 60% accurate for those patients. And that sounds like pretty compelling evidence for what Dr. Amron claims, doesn't it? But if you look at those numbers, you'll find that even though most of the calculators aren't accurate, they're not wildly inaccurate. When it says 60% accurate, all that means is that percentage of the calculators were either too high or too low. And it doesn't tell you how off they were. And actually, for quite a few patients, the calculators underestimate their resting metabolic rate. This is not at all what we would expect to see if these patients' metabolisms were completely wrecked by their lipedema. By no means are these patients starving and still gaining weight. We have a couple of studies that not only measured resting metabolic rates, but gave the patients a calorie-restricted diet based on those rates. You'll never guess what happened. Yeah, they all lost weight. I find it fascinating that Dr. Amron can make this claim about damaged metabolisms, yet he's not able to provide any evidence to support this theory. I would assume someone who's so emphatic about this point would invest in an indirect calorimeter to confirm that the patient's metabolisms were damaged. And wouldn't he like to prove that they had normalized after surgery like he claims? But as far as I can tell, he hasn't done this. People like Dr. Amron believe liposuction resets the continued fat growth, which doesn't have scientific backing. But perhaps the even more problematic belief a lot of these surgeons promote is that leaky lymphatics cause the development of fat and pain in these patients. They suggest liposuction relieves the pressure and allows better lymphatic flow, which in turn relieves a lot of the symptoms.
Okay, so with advanced lipedema patients, what we call stage 4, which have lipolymphedema, and what that means is that their lipedema has gotten so advanced with a fibrosis that begins to affect their lymphatic circulation, and that slows and eventually can permanently damage lymphatic circulation.
But remember, there hasn't been any proof that fluid causes lipedema, or vice versa. The international consensus talks about the problems with that mentality at length. Dr. Herbst and these plastic surgeons claim that liposuction is a long-lasting solution, and that diet, exercise, and even bariatric surgery do not reduce the lipedema fat. But Dr. Bertsch and his colleagues present evidence to the contrary. They review 4 studies on the effects of liposuction on lipedema, and the success rates vary widely. One study shows a 97% success rate after 15 years of follow-up. Another study shows an 84% success rate after 6 months of follow-up. Another shows a 23% success rate after 4 years of follow-up. And finally, another shows a 30% success rate after 8 years of follow-up. There are multiple problems with these studies. The first is that the success rates have obviously not been repeatable. The second is how the authors of these studies define success. It seems most of these studies focused on the patient's need for continued compression and manual lymphatic drainage after they received liposuction. And as the international consensus points out, the need for MLD is not a good metric since pure lipedema patients really don't need it. The authors of the international consensus believe that better metrics of success would be pain relief and increased mobility. Dr. Bertsch isn't against liposuction as a rule. The international consensus does recommend it for some patients with a few parameters. Number 1, the patient's symptoms persist even after 12 months of conservative therapy. Number 2, their weight has been stable for at least 12 months. Number 3, their BMI is under 35. Number 4, their mobility has been impaired by lipedema. And number 5, they can pass a psychological assessment. Actually, although Dr. Bertsch led the international consensus, his own personal recommendations are a little stricter. He thinks a patient's BMI should be under 32 in addition to all those other criteria. And I still think that's a pretty lax requirement since a BMI above 30 is obese. But in his opinion, it is a crime to recommend liposuction for a morbidly obese patient.
Personally, for me, liposuction for this morbidly obese patient is a crime. It's really a crime.
But for surgeons like Dr. Amron and Dr. Schwartz, it's no problem to do liposuction on morbidly obese patients. Anna O'Brien specifically sought out Dr. Amron because he doesn't have a BMI limit at his practice.
I flew to LA and I saw several doctors about potentially having surgery. I had also done some research about doctors in my area in Texas. I ultimately decided against local doctors because some of them had BMI requirements or they just did not have enough experience with advanced stage cases.
And what's more, when her followers have questioned why she doesn't get weight loss surgery, she's responded that because she has lipedema, weight loss surgery wouldn't work for her. An opinion I'm convinced she got from Dr. Amron or his associates. It seems there's a feedback loop going on with a lot of these patients and their surgeons. A lot of the patients featured on Dr. Amron's social media sought a lipedema diagnosis because of weight gain, and he in turn told them that they could not lose weight with diet and exercise. Liposuction was the only solution. Ever so conveniently though, liposuction isn't a permanent solution, and since a lot of these patients' weight continues to increase after surgery, they may continue to undergo liposuction several more times. This is where the idea that lipedema can occur in other body parts besides the limbs is really dangerous in my opinion. When an adult gains weight, they typically don't gain additional fat cells. Instead, the fat cells they have expand. So if you remove a lot of the cells in the legs and then you gain weight, the fat has to expand elsewhere. And one of the number one places it'll expand is the abdomen. This is part of the reason why Dr. Bertsch believes a patient should have stable weight for at least 12 months. If a patient just continues to gain, then liposuction becomes not only pointless, but sometimes harmful. The international consensus points out that abdominal fat is more metabolically damaging to the body than fat on the legs. And unfortunately, it seems a lot of Dr. Amron's patients are under the impression that They're gaining abdominal fat not because of a poor diet, but because their lipedema is progressing to their abdomens.
I want to point out to you the lipedema changes before and after surgery. You can really see the lipedema in my arms prior, even though my torso wasn't affected yet, it hadn't progressed. You can really still see the arms at this point.
Dr. Amron, Dr. Schwartz, and plenty of other plastic surgeons in this space promote the idea of abdominal lipedema. That means they also perform tummy tuck procedures on these patients. But Dr. Bertsch insists that this abdominal fat is not due to lipedema. He thinks if patients with morbid obesity should have any kind of surgery, it should be weight loss surgery. The international consensus provides an example of a woman who is morbidly obese, diagnosed with lipedema, and was recommended 7 sessions of liposuction for the price of about 18,000 euros. The clinic who recommended liposuction didn't even list obesity as a condition in the patient's report, even though she had a BMI of 54. Thankfully, that patient sought a second opinion who recommended weight loss surgery instead. She agreed to it and not only lost half her body weight in 14 months, but she also lost half the volume of her legs. You know, the fat that is supposedly unburnable by diet.
We could convince her that bariatric surgery is the best option for her problem, and we admitted her in our obesity program and prepared her for a gastric bypass, and this was the patient 10 months later, and she was free of any complaints. So we call this lipedema in remission.
Weight loss surgery isn't magical. It mostly just reduces the amount of calories a person is able to consume. After weight loss surgery, this patient also found a lot of her other conditions improved, including lymphedema, venous insufficiency, and hypertension. If the first clinic convinced this patient that all of her fat was due to lipedema, and she did get liposuction, then they may not have actually addressed the root cause of all of these issues. Obesity. Maybe she would have experienced some relief from her symptoms, but if she didn't change her eating habits, the fat was just going to come back, possibly in even more dangerous places. 18,000 euros down the drain. The authors of the international consensus provide several more examples that suggest bariatric surgery will work for obese lipedema patients. In their opinion, lipedema is definitely a complicated condition, but it doesn't cause obesity and it doesn't prevent weight loss. If anything, the addition of obesity seems to make lipedema worse. To me, this is pretty compelling evidence that for a lot of patients, liposuction isn't medically necessary. And it seems that giving a person with morbid obesity liposuction just slaps a band-aid on the symptom without getting to the root problem. This is a part of the whole debate that really gives me the willies. There's a whole cottage industry of plastic surgeons who offer liposuction for lipedema, and it's clear that a lot of those patients are obese. Dr. Amron insists that a lot of his patients do go on to lose more weight after liposuction because it fixes their metabolisms or whatever. I'm not sure where he's getting that information because we can see that at least 2 of his influencer patients have put on abdominal weight since surgery. And those are just patients that we see online. This isn't me trying to body shame these women. I'm worried about them. Like I said before, Anna O'Brien says she won't get weight loss surgery because it wouldn't work for her. All of her fat is lipedema. And yeah, a lot of my regular viewers would say, Anna is often delusional and dishonest, and I do agree with that, but it's a lot easier to be delusional when your doctor is going along with your delusions.
And she can find herself starving, eating very, very little, and she's still putting on weight, right?
I don't think every obese person needs weight loss surgery or weight loss medication. I had a BMI of about 35 at my heaviest, and I lost weight just by counting calories. But I think a lot of these patients, people like Anna, really could benefit from weight loss surgery. In older blogs and videos, she readily admitted to struggling with overeating, even calling herself a food addict. But now she's changed her tune. She has doctors telling her that her weight gain is all due to this condition, and she wouldn't lose weight if she dieted. It's interesting to me that someone like Dr. Amron insists that advanced stage patients like Anna need liposuction the most urgently, whereas Dr. Bertsch would say they're the patients who need liposuction the least.
They continue to advance and get worse. I've honestly seen in stage 3 and stage 4 patients, they still can't come to grips with the need for surgery. And I'm careful about how I say that because I don't want to be perceived like I'm trying to just have patients do more and more surgery. If they can't kind of break past that thing and do something that's actually important, it's setting this disease back. And it's progressing despite their best efforts.
there's a cost to that also.
Personally, for me, liposuction for this morbidly obese patient is a crime.
And by it's interesting, I mean it's concerning and frightening. If these patients' weight is not caused by lipedema, then they also just have obesity, which does lead to plenty of other health problems. I don't think it's a coincidence that many lipedema patients also have the comorbid conditions that occur with obesity. I also don't think it's a coincidence that so many lipedema patients struggle with their mental health, when that's also an issue with many obese people. It's a vicious cycle where mental health issues can lead to weight gain behaviors, and weight gain behaviors can also affect your mental health. In that case, in addition to treating their lipedema, they urgently need treatment for obesity, whether that's bariatric surgery, weight loss medication, or a nutritionist and therapy. But Dr. Herbst's fear obviously doesn't see it that way. Remember when I wondered if Dr. Bertsch just wasn't aware of all the research Dr. Herbst put forth? Well, clearly he was, so now I have to turn the question in the other direction. Do Dr. Herbst and her colleagues know about these refutations for their research?
Chapter 13, Infighting.
So as we have established, these two consensus groups, Dr. Herbst's Standard of Care Committee and Dr. Bertsch's International Lipedema Association, have very different philosophies. And at first, early on in my research, I wondered if they were aware of each other. That was probably a dumb question, but I don't know a lot about the medical research field. To me, there was such an ideological divide between Europe and the Americas that I really wasn't sure. I found out that not only were they aware of each other, but they were actually embroiled in battle. When Dr. Herbst and her colleagues became aware of the international consensus, they leapt into action. In December 2020, only a month after the international consensus was published, Dr. Herbst and some of her colleagues appeared on a webinar hosted by LIO, or Lipedema Italia. LIO is a nonprofit organization in Italy, and it's mostly run by lipedema patients. This organization was not happy about the international consensus, and they brought in Dr. Herbst and others to make a case against it. You can find a recording of the webinar on the LIO YouTube channel, and it's titled Lipedema, Not a Closed Case, a New International Consensus. And here's how Dr. Herbst describes the international consensus.
So the Journal of Wound Care International Consensus document, which was already introduced to you, in my opinion, strives to classify lipedema as simple obesity.
Huh. That's an interesting description, isn't it? We've been talking about the international consensus for a frankly ridiculous amount of time at this point, and would you call that a fair assessment? I sure wouldn't. First of all, I can tell you emphatically that the international consensus does not classify lipedema as simple obesity. That's frankly an insulting characterization of what the authors say. Here's what the international consensus actually says. Quote, "Nevertheless, and this needs to be emphasized, many patients referred to the specialist clinic with a diagnosis of lipedema also have two other diseases in need of treatment, obesity and obesity-related lymphedema. Obesity treatment and complete decongestive therapy are, of course, still the mainstays of treatment for these two conditions, but they are certainly not suitable to treat the complex disease of lipedema." End quote. There are several more sentiments like this in the international consensus. It's so very clear that they do not believe lipedema is simple obesity, or that both conditions should be treated in the same way. I have a very long list of videos in a playlist that I've revisited several times over the course of my research, and I'll try to make that playlist available to you whenever I publish this video. But this LIO webinar was one that honestly just made me mad when I rewatched it. It was difficult for me as a non-scientist to understand this research, but I don't think it takes an expert to understand that the international consensus was not calling lipedema just obesity. As a doctor and researcher herself, I'm not sure how Dr. Herbst could have come to that conclusion. So there are a couple of possibilities. Either Dr. Herbst really didn't understand the document, or she did understand the document, but she's hoping that the people watching this webinar didn't read it. I can't say for sure. Now let's address Dr. Herbst's second point.
It attempts to reduce available treatments for lipedema that we know work.
There's that we again, but at least this time I know who the we is. The Standard of Care Committee. Several members of the committee were on this webinar, and while the Standard of Care hadn't been published at the time of this recording, The work was well underway. So what treatments are the international consensus apparently trying to reduce? Mostly MLD and liposuction. I think at this point I've established why those two treatments are not always the best for lipedema. Dr. Bertsch's international consensus is not trying to take away therapies that work. Why would they want to do that? Well, maybe the argument is that they're trying to push more patients into bariatric surgery instead. Surely there is a profit motive if lipedema is simple obesity, right? But despite what Dr. Herbst says, never does the international consensus say that bariatric surgery, or weight loss in general, is a cure for lipedema. It does state that weight loss often improves symptoms, and the Standard of Care Committee agrees with that. But the international consensus also recognizes lipedema as a different condition that requires other treatments. Again, ones that both sides agree on. Compression garments, nutritious food, exercise. They all agree that these are evidence-based treatments for lipedema. And like I mentioned before, the international consensus says liposuction is an acceptable treatment for some patients. For most treatments besides MLD and compression pumps, the authors of both documents agree. The international consensus just promotes more evidence-based treatments and evidence-based parameters around those treatments. But as I think we've already established, the Standard of Care Committee has different ideas of what qualifies as evidence. So who is this we who know these treatments work? Dr. Emily Eicher, who operates an MLD practice, Dr. Thomas Wright, a plastic surgeon, and Linda Ann Kahn, all members of the Standard of Care Committee, of course. Remember when we talked about differential diagnosis? I was a little critical of the Standard of Care Committee for not considering it as much, but there is an example of it in this webinar.
This is an example of a woman in the consensus document who had bariatric surgery, and the authors claim that this woman has lipedema and it is completely reduced by bariatric surgery. However, I and my colleagues on the Standard of Care Committee in the US noticed that this woman has central obesity. She does not have that classic small waist, larger legs.
Our European colleagues say it does not occur in the trunk, and we believe it does.
Agreed. Completely. Agreed. Completely.
In fact, she has a lipodystrophy of her lower legs and her arms, which is common when metabolic disease is present. So I think this woman has obesity with metabolic disease. Dr. Tom Wright also noticed that you can see the varicose veins on her legs. She also has a darkening of her skin here on her lower legs and a gaiter distribution, and she has corona phlebitictica, all markers of chronic venous disease.
We just completed a procedure to treat her veins. It doesn't cure the lipedema, but vein problems can coexist and aggravate the lipedema symptoms.
So this is a woman who has obesity and chronic venous disease, and we do not think she has lipedema. If she does have lipedema, it is a very small amount. So this is wrong.
Oh, that's so convenient. You get an example of a patient who has lost weight in their legs with bariatric surgery, and suddenly you have all kinds of other diagnoses to offer. Now, I'm not saying that Dr. Herbst is completely wrong, because we really have no way to be sure if this patient was correctly diagnosed. Since there is no definitive diagnostic test for lipedema, doctors just have to do the best they can. But she's acting like this is the only example that we have. The international consensus references a retrospective study of 31 lipedema patients and 14 controls that found bariatric surgery caused them all to lose weight in their legs at about the same ratios. Obviously, a retrospective study of this size isn't the best we could ask for. It would be hypocritical of me to think this is some kind of amazing evidence, but I think it's a decent starting point. My question is, though, would Dr. Herbst insist that all 31 of the lipedema patients in that study were misdiagnosed? Are we just supposed to accept only the lipedema patients that Dr. Herbst has approved herself? Someone could very easily turn that around on her and say that the patients in her studies were misdiagnosed. This is part of the problem with studies on these clinical diagnoses. But I would argue that Dr. Bertsch's definition of lipedema would be more likely to catch true lipedema patients, because he requires both lipohypertrophy and pain in the soft tissue to qualify. And since we know Dr. Bertsch requires those symptoms, We know that all the patients in the study did have them. So how does Dr. Herbst explain that? Is she trying to tell us that if these patients showed up at her office instead, that she diagnosed them with simple obesity? For some reason, I highly doubt that. And what if these 31 patients had seen someone like Dr. Herbst instead? Would they have gotten weight loss surgery, or would they have been referred for liposuction? I think it's a distinct possibility that they would have been referred for liposuction. And that's something that unfortunately probably happens with some of these patients. Dr. Herbst also asks for the plastic surgeon Dr. Thomas Wright's opinion on this bariatric surgery example. And he stumbles through an explanation of a study that he's taken part in.
I'm first going to ask Tom Wright a question. Tom, if you're on, is lipedema tissue resistant to loss by diet?
So there was I participated in a very good study at Washington University, and we did a weight loss study. It was highly controlled. I'll go into the methods in the next slide, but basically the subjects with lipedema underwent a 10% body weight loss, and it had no effect on their lipedema symptoms.
The first thing I need to say is that I looked up this study, and I couldn't find it. I could find things about the study, like Facebook posts asking for participants, mentions of it on his website, and even an article from 2 years after this webinar that described the study as underway. But I was able to find what I believe is the trial ID number for this study, which led me to the study parameters on clinicaltrials.gov. I hadn't heard of this website before, but I think I'm in love with it now. It's just a wealth of information. You should check it out. What I learned was that the trial is indeed still underway, and it's not estimated to be completed until 2025. How are you presenting all these conclusions in 2020 when the study hadn't even been completed? Tom, let's just go off of what Dr. Wright presents in this webinar. We'll just take his word for all these findings.
While they did lose some weight in their legs, the proportion of their body fat proportions remained unchanged by the weight loss.
I have to say, I can't find the origin of this graph either. He just credits Dr. Herbst 2020 at the bottom, so I assume this is data from the study that will be published later. I would have loved to actually see the data that goes along with it, but here we are. But his entire argument is that the women in this study did lose weight, including in their legs, but their proportions were unchanged. And I failed to see the issue here. The question from Dr. Herbst was, is lipedema tissue resistant to loss by diet? The answer, according to the pieces of this unfinished study, is no.
The subjects with lipedema underwent a 10% body weight loss.
These women did lose some weight, but they remained proportionally the same, meaning they lost about the same percentage of fat in all areas. Why would we expect anything different? If a person starts with more fat on their legs than usual, then chances are they're still going to have more fat on their legs than usual after a pretty modest 10% weight loss. That was never part of the argument. Dr. Wright wasn't the only one who presented research that was difficult to find. I'm not saying impossible to find, just that I wasn't able to find it.
So Emily Eicher, can we ask you how effective is conservative management for lipedema?
Hi, good morning, good evening, everybody. Thank you. It's a great honor to participate with this fantastic meeting. With the ultrasound study, I showed that when we do light massage, light manual lymph drainage, followed by compression pump treatment, half an hour of massage, we achieved only 14% reduction measured by ultrasound on the same space as previously measured with ultrasound. When we combine light massage with compression pump treatment, we achieved a total of 37.8% reduction. Right, with deep tissue massage, where we have to break the fibrotic tissue, we achieved 28% reduction just after manual drainage treatment of 30 minutes for both legs. Now, when we combined it with compression pump treatment, we achieved 39, close to 40% volume reduction.
I realized her audio was terrible. I apologize for that. That's why I sped her up a little bit. But I just wanted to break everything down just in case you missed it. So she's saying her findings are that light MLD massage alone on the legs caused a 14% reduction of volume. Light MLD massage plus compression pump resulted in 37.8% reduction. Deep MLD massage alone resulted in 28% reduction, and deep MLD massage plus compression pump resulted in 39% reduction. Wonderful, Dr. Eicher, but where is this research from? I am begging people to just include the study title in the caption or say where their findings came from. Because if what Dr. Eicher is saying here is true, that's great. Revolutionary even. I just can't find it. I did find studies with her name on it that include ultrasound scans, but this is a completely different study with different photos and different findings. I was even able to find Dr. Eicher using a very similar slide on a video by Lymphopress, and she still doesn't say where it came from.
Interesting study we did just recently where we compared light and deep manual lymph drainage and combined that with intermittent pneumatic compression pump. And with deep MLD, we achieved 29.7% reduction. But when we combined this with MLD and compression pump, we achieved 38%. And yes, it was by Lymphopress.
I feel like I did my due diligence trying to find this study, but I got nothing. We should also pay very close attention to what Dr. Eicher says that compression is doing. She says that compression reduces subcutaneous space, which I'm not an expert, so I don't know if I have this exactly right, but it seems to me that compression is reducing the space between the skin and the fascia, and I'm willing to believe that compression could do that. I don't know enough to say whether it couldn't, but you'll notice that what she's not saying is that this compression is reducing the fat, which is something that I have heard some of these experts say in other places.
We've seen patients have reduced pain, increased mobility, and even reduction.
Manual lymphatic drainage therapists can reduce the size of lobules and provide compression garments that can contain those lobules.
I don't know. I just noticed that she repeated the word reduction a lot of times. And I'm afraid people are getting the impression that she's talking about the reduction of fat when there's really no evidence that that's going on here. I mean, even if we did have a study to look at. Because as far as I can tell, other published studies about compression didn't find that it reduces the fat. That really wouldn't make any sense. As a side note, Dr. Herbst mentions that the international consensus proposes a new name for lipedema, Lipalgia syndrome, which you may remember means painful fat syndrome. She asks if that term is an appropriate change. More specifically, she asks Linda Ann Kahn, obviously my first choice too.
So, Linda Ann Kahn, I would like to ask you, does Lipalgia syndrome adequately describe lipedema? And this is what the authors propose as a new term for lipedema.
So the answer is actually no. Pain is a very important criterion when we diagnose lipedema, but it's not an absolute requirement for lipedema.
And to that I say, okay then, why is lipedema more appropriate? You can't demonstrate the edema. Why am I even entertaining this? This video is one of my first introductions to the dispute between the international consensus and the standard of care committee. The first time I watched it, I didn't fully understand either Dr. Herbst's position or Dr. Bertsch's position. But now that I have more context, I am personally struggling to find competence and, well, honesty in this video. It feels to me like this group of people is misrepresenting the information to paint the international consensus and its authors in the worst light possible. In a similar vein, Dr. Herbst gave a speech at the FDRS conference in 2022 discussing the ILA and the international consensus. And let's just say this speech was a little more fiery than usual.
Now, if you haven't heard, there is a new association called the International Lipedema Association. So that pissed me off. And
What is Dr. Herbst so pissed off about? A few things. First of all, she doesn't like how there are no patients included in the International Lipedema Association.
And you can actually go online and you can look at this society yourself. But I will tell you, they don't include patients. And they don't include patient groups. It's only professionals. And they don't feel that they need the patients. Whereas I feel like you guys are the patients and you're allowing us in.
But to me, that's so silly. This is not a support group, it's a group for healthcare providers. I said before, and I'll say again, just because I have an illness doesn't make me an expert in treating it. Of course, it's a great idea to talk to patients and learn about their experiences, which is probably why on the ILA's website, one of their goals is, quote, building the bridge between healthcare professionals and patients and valuing their knowledge and experience, end quote. Not that Dr. Herbst would mention that. What else pissed off Dr. Herbst? The fact that the international consensus disputes the use of MLD and compression pumps because there's no evidence of fluid in lipedema. But that's not exactly how she phrased it.
And what this group also says, and they have a brochure that's out online and you can download the brochure, there is no edema in lipedema. There's no fluid in the tissue. Lipedema does not cause lymphedema, and it does not worsen over time unless you have obesity. Only if you have obesity does your lipedema worsen over time. Okay, so here are your therapies. In their association, there is no MLD for you. You wear compression garments, not because you swell, but only for the pain. There's no pumps, no compression pumps for you because you don't have edema in your tissue.
This is so ridiculous. These are scientists presenting their research, and she's making them seem like Disney villains. These authors are not breaking into their patients' homes in the night to take away their compression pumps. What really jumps out to me in this talk is how easily Dr. Herbst slips into doublespeak. She stands there defending compression pumps and MLD, insisting that these are absolutely necessary treatments for
Lipedemons, right? Got to get we got to take care of our lipedemons, and how are you going to do that with without all this stuff? So,
okay, but what are the demons? I noticed she didn't say edema. She just implied it by saying these treatment methods work. But we already know from her other work that she does insist pretty emphatically that the edema theory is correct. But then she tells the audience, well, we're actually forming a new international group and we're different.
I've been working with the Lipedema UK, Lio Italia, and Limpa from Portugal. And we are going to start another group. And they have kind of a name, but it's not been incorporated. We just got funding for it. And what we want to do is to be open to all science. We don't think it's early enough to put a kibosh and say there is no this or there is no that. We just don't have good scientific backing. So what I say is there are two sides to the coin. Whether there is edema and lipedema or there's not edema and lipedema, we don't know yet. If you only look at one side of the coin, it's like saying that the world is flat.
She's trying to say the edema theory isn't a closed case and we don't actually know for sure yet, so she's just keeping an open mind. But all of her work tells another story. I mean, frankly, this talk tells another story. Like 2 minutes ago when she was telling us how MLD works. To me, it seems like she's just trying to make the ILA look like a bunch of ivory tower ideologues. They're too close-minded. They won't let patients in. They're taking your treatments away. Dr. Herbst always talks a big game about how open she is to accepting new science, but it feels like she's only open to accepting science that supports her own theories. And why might that be? I can't think of any reasons. Okay, dear audience, I've actually been holding out on you a little bit. I know, this far in, can you believe it? From 2018 to 2020, shortly before the international consensus was published, Dr. Bertsch published a 5-part series titled Lipedema, Myths and Facts in the medical journal Phlebology. By the way, these articles are great resources if you're interested in this research, because they divide a lot of the points from the international consensus into smaller, more digestible pieces. I wouldn't know anything about that. These articles say a lot of the same things we've already discussed. Popular claims about lipedema and some common treatments don't have much scientific evidence. But more importantly, he pins a lot of these popular misconceptions on Dr. Herbst and her colleagues. He names Dr. Herbst directly multiple times in these articles, each time calling her a protagonist of the American lipedema scene. I didn't even know protagonist could feel like an insult. Well, Dr. Herbst didn't appreciate these articles very much, and she, along with the rest of the Standard of Care Committee, wrote a letter to the editor in 2020. She presents, again, a lot of the same evidence that she gives in other papers and talks. But what followed was the most devastating takedown I have ever seen, because Dr. Bertsch and a colleague published a response to Dr. Herbst's letter to the editor. Dr. Bertsch says, quote, "For those interested in Herbst's understanding of science, this paper, Lipedema is Not Just Fat, is recommended. The statements she made there were in no way comprehensible to us," end quote. Annihilated. If you'll remember, I took their recommendation to read it myself, and yeah, I agree. A lot of this response just reiterated things we've been over. Dr. Herbst's citations were either her own work or didn't actually make the claims she said they did. But Dr. Bertsch also presented a piece of information I didn't know. The paper he mentioned, Lipedema is Not Just Fat, was published on lipedema.com. It was published only on lipedema.com. It's not in a single scientific journal. Go ahead and Google it. That's the only place you'll find it. And that's bad enough, but it turns out that lipedema.com is Dr. Herbst's own website, which she operates with Dr. Eicher and Linda Ann Kahn. But it doesn't stop there. The next part is so wild, I'm just going to have to read it to you in full. This is a quote from the introduction of Dr. Bertsch's response. Quote, "We are aware that in the USA, the old narrative regarding lipedema is still being retained. There, 3 patient organizations with strong media coverage and strong financial backing, as well as a few physicians closely associated with these organizations, dominate the opinion on lipedema. Lipedema Simplified by Catherine Seo, Fat Disorder Research Society, and Lipedema Foundation, the latter two being interconnected closely. Felicitie Daftuar is both a member of the leadership team of FDRS and founder and executive director of Lipedema Foundation. This is important to note, as the author of the letter to the editor, Karen Herbst, is very closely connected to FDRS, as well as to Lipedema Foundation. Since 2015, Felicitie Daftuar has been supporting Karen Herbst's projects with millions of dollars," end quote. When I tell you I was pacing the floor in a cold sweat when I read that, let's go over that again, just to make everything super clear. In the US, 3 organizations dominate popular opinions on lipedema. One is operated by a woman named Catherine Seo, and the other 2 are operated by a woman named Felicitie Daftuar. At least they were at the time of that publication. And Felicitie Daftuar in particular is incredibly wealthy and influential, and she's been supporting these organizations and Dr. Herbst's work with, again, millions of dollars. I briefly mentioned the only study I could find that contained possible evidence of edema and lipedema was co-authored by Dr. Herbst, and it was funded by the Lipedema Foundation. The 2017 study that looked at hypermobility, you guessed it, funded by the Lipedema Foundation. Dr. Herbst also had a whole research project called the TREAT program at the University of Arizona, which was funded by the Lipedema Foundation. And it's not just Dr. Herbst. Where did I find that trial ID number for Dr. Wright's unpublished study? The Lipedema Foundation website. Felicitie Daftuar's foundation is financially backing that study. And the foundation is not shy about this. You can find a whole list of studies they funded on their website. They say, quote, "We have funded about 20% of the lipedema work published in recent years. Since our funding program began in 2017, our research investments have moved lipedema knowledge through evidence presented in the publications listed below," end quote. And then there's a list of 44 studies they've sponsored. Now, it's not necessarily suspicious that a foundation formed around an illness would fund studies for that illness, but 20%? That's an insane number. By comparison, in 2020, all nonprofits combined funded only 1.2% of medical research and development in the United States. So 20% is a significant chunk. You could make the argument that since lipedema is a rare illness, that does kind of make sense. It's sad, but in the United States, most funding for medical research comes from corporations. That's largely because they want to discover and, more importantly, sell treatments. For rare and sort of ambiguous conditions like lipedema, there's far less profit motive for industries to research them. So the funding kind of has to come from nonprofits or the government. But that means that the Lipedema Foundation, as well as the FDRS and Lipedema Simplified, are the biggest voices around lipedema in the US. These organizations made it possible for Dr. Herbst and her associates to become the leading researchers in the US and in some cases in the world. Theoretically, these two people have the power to shape how lipedema is researched and understood. That's an enormous amount of power. So I had to ask, who are Catherine Seo and Felicitie Daftuar? And what exactly are they doing with their influence?
Chapter 14, Dr. Catherine Seo.
Yes, Catherine Seo technically deserves the title of doctor, but that's because she has a PhD in media psychology. I respect PhDs, but I don't want to give anyone the impression that she's a medical doctor. She is anything but. So let's just call her Catherine. Catherine Seo is the founder of Lipedema Simplified LLC. Yes, this is a business, not a nonprofit, but she is also the co-founder and co-director of the Lipedema Project, which is a nonprofit that kind of evolved from Lipedema Simplified.
I partnered with the Friedman Center for Research and Treatment at Mount Sinai Beth Israel in New York City, and we've created the Lipedema Project, which is about raising awareness for women who might suffer from lipedema. There are 17 million women, an estimate of that many women who have this disorder in the US and don't know about it.
The Lipedema Project was also co-founded and co-directed by Dr. Mark L. Smith, a plastic surgeon. The Lipedema Project's website thanks Dr. Smith for his generosity and vision, and I just have to wonder if generosity is code for financial contribution, because it seems that although Catherine Seo has a lot of passion for increasing awareness, she perhaps didn't have the funding or connections to accomplish that goal on a large scale. But together, Catherine and Dr. Smith created something that the Lipedema Project is perhaps the most famous for, a 2015 documentary titled The Disease They Call Fat. This documentary is a little under an hour long and it's available for free on YouTube, so I won't cover everything here. But what I will tell you is that, in my opinion, there is a ton of misinformation and frankly, nonsense in it. One of the biggest issues with this documentary is their focus on framing lipedema as a lymphatic disorder.
Lipedema can cause lymph fluid to leak into the surrounding tissue. This buildup of fluid causes swelling and is called edema. Over time, edema can damage the lymphatic system, resulting in further swelling. Swelling caused by an impaired lymphatic system is called lymphedema. And when lymphedema is a result of the progression of lipedema, it is called lipolymphedema.
That there is
there's Dr. Roxon.
Between the function or malfunction of the lymphatic channels. And when you think about it, a growing number and growing size of fat storage cells is another way to accumulate fluid. It's just that the fluid is in the cells instead of around the cells.
So some people have more
there's Dr.
fluid in
Herbst.
the lipedema fat than others. And so the more fluid you have, the more you're going to respond to manual lymph drainage, compression, pool therapy, all the 9 yards. So that's how you get the fluid out.
But as we've already gone over exhaustively, there's really not much evidence to support these ideas. Another big issue with this documentary is it's framed as educational and uplifting, but it's hard for me to not also see it as an ad for MLD and liposuction. Oh my god, of course Dr. Amron is here too.
More newly identified condition. In the US, unfortunately most doctors still don't know about it.
And Linda and Kahn.
Therapists go through intensive certification, understanding the physiology and anatomy of the lymph system, decongest the tissue, helps with toxic waste in the body.
I had obviously seen this documentary before I started writing my script, but I rewatched it for this portion of the video, and I just didn't realize how many of the usual suspects were in it, all here to educate thousands of people with scientifically unproven and unsupported theories. It's like, if you want to research lipedema in the US, you're just going to be in this echo chamber because the same people are in everything. But maybe the most concerning issue with Catherine and this documentary is their focus on weight. I mean, look at the title itself. The disease they call fat, that's not at all an accurate description of lipedema. Yes, lipedema does involve disproportionate fat, but that's not the whole story. But as far as this documentary is concerned, unexplained weight gain is the primary symptom of lipedema. Not just disproportion, but whole body weight gain.
Always struggled with my weight. I knew that my legs were
were larger than they should be.
You're growing fat, you eat too much.
My legs started getting bigger.
Really thick elephant legs, as my mom and I would call it.
The immobility has been so debilitating that I can no longer work.
I would go to the doctor and I was told I was too fat and to take diuretics.
I did everything I could to try and lose the weight and nothing seemed to work.
Tried every diet, been on a diet since I was 7 years old, I think. But nothing ever made the legs get smaller.
Well, I need to do more, and even more, and I thought I can't do any more.
And I stopped eating, and I had so many issues with my metabolism, and I was malnourished. I was a fat person that was malnourished.
That's where patients themselves buy into the social value system that, you know, they must be eating too much and not exercising enough, and yet they may be, and it's just something that's beyond that.
Again and again, the patients and professionals describe lipedema as unexplained weight gain that doesn't respond to diet and exercise. There are quite a few patients in this documentary who are overweight and obese. Do I believe they could have lipedema? Absolutely. But this documentary frames their weight as being caused by lipedema. In their view, it's practically one of the diagnostic criteria. I've seen enough evidence at this point to say that's simply not true. What do the experts in the documentary have? They have the edema theory, supported by basically nothing.
Laura has lipedema tissue. It's very easy to feel nodules in her tissue. And then on her hips, she has lymphedema. And you can typically see it on their lower legs, and they get ankle edema, and you can even see it on their feet.
Over 100,000 people have seen this video on YouTube, and who knows how many others have seen it elsewhere. In my opinion, they're getting a completely inaccurate view of lipedema, and I'm sure a lot of them have no idea that's the case. And why would they? I think a lot of people, myself included, have a predisposition to view documentaries as well-researched and respectable. If they try to fact-check, they'll probably come across the same research from the same people. Dr. Herbst, Dr. Amron, Dr. Roxon, Linda Ann Kahn. They're everywhere, and they're promoted as leading experts. But it's actually worse than that, because Catherine Seo and Dr. Smith collaborated to create a book based on the documentary, titled The Disease They Call Fat, an Overview for Clinicians. Great, not only are thousands of people potentially being misled by this documentary, but the creators are promoting it to physicians. Actually, more likely, they're promoting it to patients who are then giving it to their own physicians. There is so much talk of educating your doctors in this community. Catherine Seo and many others in this space insist that lipedema is actually not rare, it's just that doctors don't know about it.
I tried a 5-day fast, nothing, water, 5 days. Lost no weight, and then the minute I ate again, a salad, 5 pounds up again. So I told him that, and he looked at me and said, you know how I know that's not true? I said, how? And he said, because there are no fat people in refugee camps. That was what he said. So I knew then, he does not believe me. There's nothing this doctor can do to help me.
I understand why a lot of these patients feel like they're being dismissed. For many patients, it takes a long, long time to get a diagnosis, and that is because a lot of doctors either haven't heard of lipedema or believe it's better explained by other diagnoses. And I'm willing to believe a lot of doctors really aren't educated on it, but when the education you're giving them is riddled with unsupported theories, I think you're going to have a problem. Unfortunately, though, if these patients' doctors reject those theories and insist that the patient's weight gain is not due to lipedema, they're often called medical gaslighters. A lot of Dr. Bertsch's detractors consider him a medical gaslighter because he disagrees so fundamentally with other experts.
Another myth in the consensus document is that lipedema makes patients fat. And I'm apologizing to you for these next 2 sentences, which to me are inappropriate to use when discussing patients and are misogynistic. Women believe lipedema is responsible for their long history of weight gain, say the authors. It is laborious and time-consuming to convince patients that they are misinformed and that there are other factors that lead to an increase in weight, and it is certainly not due to lipedema. So the authors think most women with lipedema are obese, with some underlying lipedema. But dismissing the possibility that lipedema tissue can increase over time without proof is non-scientific. We need more data.
There's never any room for seemingly unexplained weight gain to be anything else. Either you have lipedema and your doctor agrees and diagnoses you, or you have lipedema and your doctor is gaslighting you. It really creates such an antagonistic relationship between patients and doctors to the point that a lot of patients just automatically assume that their doctors don't want to help them.
People have that physicians have, no matter how much they say, I'm just going down a checklist of symptoms, it's not true. You have a bias. And so they're going to look at you and they're going to say, oh, you're just overweight.
I am generally annoyed by Catherine Seo's influence, but it's hard to not feel sympathy for her. She created Lipedema Simplified, the Lipedema Project, and this documentary because she herself is a lipedema patient.
For years, I've suffered with weight issues. Perimenopause brought on an unexplainable weight gain. And after 5 complicated surgeries that were based on a misdiagnosis, I found out that I have a fat disorder called lipedema. To tell the truth, I didn't know there was such a thing called lipedema. And I'm not the only one.
She was struggling and she had so many unanswered questions about her own condition. It's just really unfortunate to me that not only has she been steered wrong herself, but she's potentially steering so many other people wrong too.
I'm gaining weight. I don't know why I'm gaining weight, and they wouldn't believe me. You know, I would say I weigh and I measure my food, and I do that without exception, and I write it down. Here's a log, and they wouldn't believe me.
Catherine Seo may not have a multi-million-dollar foundation, as far as I can tell, but she has a ton of influence in this community. Catherine is much like a lot of the other specialists in this documentary. Once you know her, you start seeing her everywhere. She's considered a lipedema expert, and she gives talks often. She even offers coaching on her website. Imagine that. This documentary is just one example of the pervasive, questionable information she's promoted throughout the patient and professional communities. But even more influential than Lipedema Simplified or the Lipedema Project are other organizations Dr. Bertsch mentioned in his response letter, the FDRS and the Lipedema Foundation, both at one time run by Felicitie Daftuar.
Chapter 15, Felicitie Daftuar.
Felicitie Daftuar is not a medical professional nor a PhD. She's a businesswoman. Her LinkedIn experience lists 3 things. She was a project manager for Motorola in the 2000s, but she apparently left that job to get her MBA. The only other things on the list are the FDRS and the Lipedema Foundation. I'm not sure what it pays to be project manager for Motorola, but I feel like that's maybe not where her millions came from. That's a mystery I've not been able to solve so far. Maybe familial wealth? I have no idea. Okay, so I did some more digging, and it looks like Felicitie Daftuar might be married to someone who is like a co-owner of a cryptocurrency business. So that might explain where the millions came from. I also found this nonprofit called the Daftuar Family Foundation, and they're both listed as trustees receiving 0 compensation. But you can find these 2 names together in a lot of places, especially charity donations. Very philanthropic, these 2. Now, I can't prove any of that beyond a shadow of a doubt. I don't know exactly where their money comes from. I don't even know if they're married. But that's just my assumption based on the things that I found. Regardless of where her wealth came from, she clearly has an agenda. It turns out Felicitie Daftuar isn't just a former leadership member of the FDRS. She actually kind of resurrected it. The Fat Disorders Resource Society used to be called the Fat Disorders Research Society, and it was founded in 2009, 4 years before Felicitie took over. Interestingly enough, Dr. Herbst has been a featured speaker at the conference since 2010, and Linda Ann Kahn has actually been speaking since the first conference in 2009.
Hi everybody, I'm so happy to be here. I've actually spoken and been at every single conference since the beginning, and it's So I was in Chicago in 2009, so it's wonderful to be here.
They've clearly been deep in this space since the beginning. Some setbacks in 2012 almost caused the old FDRS to collapse, but Felicitie Daftuar took over as president in 2013 and completely reorganized, including launching their YouTube channel. In 2015, she stepped down as their president and became board member and research coordinator.
Hello, and welcome to the Fat Disorders Research Society, or FDRS. We are a United States-based 501c3 nonprofit organization that was founded in 2009. Our current board members consist of Felicitie Daftuar, Yvonne Russell, Nancy Lazarus, Laura Baker, and myself, Cheyenne Brinson, a volunteer with FDRS. We're also supported by a medical scientific board, which includes Dr. Karen Herbst, a clinician out of the University of Arizona, Dr. Joseph Stutz, who is a liposuction surgeon in Germany, and Linda Ann Kahn, who is an expert in nutrition and wellness.
She's since left all her roles in the FDRS, but her legacy remains. This conference is now huge in the lipedema community. People who speak there are treated like celebrities. Dr. Herbst is perhaps the biggest celebrity of all in this community. So it's no wonder Felicitie Daftuar took interest in Dr. Herbst. Like Dr. Bertsch said, Felicitie has poured millions of dollars into Dr. Herbst's research, but Dr. Herbst isn't the only one who benefits. The FDRS conference is an opportunity for patients and professionals to convene, but it's also an opportunity to market. Who were the sponsors of the 2024 conference? The platinum sponsor was Total Lipedema Care, the plastic surgery practice run by Dr. Jamie Schwartz. Other sponsors include Dr. Amron's Advanced Lipedema Treatment, which is plastic surgery, Art Lipo, plastic surgery, Liposuction Surgical Solutions, obviously plastic surgery, Dr. Michael Schwartz, plastic surgery, Granzow Lymphedema and Lipedema Center, plastic surgery, Krokmal Center, you guessed it, plastic surgery, and finally, one compression garment company called Bioflect. I also encourage you to go to the FDRS 2024 sponsorship opportunities page to see what kind of price tags they were looking at. That's not even including the exhibitors who got to have booths at the conference, Lymphopress, Tactile Medical, and plenty of other companies who produce compression and other treatments for lipedema. And lest we forget, Cover Lipedema, a patient-led website that offers to help you get your liposuction covered by insurance for a membership cost of $1,400. Look, I know it's not unusual for conferences to have sponsors with a vested interest in the people who go there. It's not unusual for exhibitors to have booths to sell things and hand out business cards. None of this would be a huge red flag to me, if not for the standard of care. I can't put it any better than Dr. Bertsch did in his response letter to Dr. Herbst. Quote, "A final word on the co-signers of this letter. Nearly every person listed there is connected with the U.S. Standard of Care Committee. If you enter this supposed organization in Google, you will not find any entry. However, you can find them on Herbst's own website, lipedema.com, mentioned above, where the author of the letter, Karen Herbst, was also able to publish her contribution to the GAGs. There, they refer to a meeting that took place in April 2019 in Baltimore, and in which 18 of the 22 co-signers took part. The author of the letter to the editor and the two patient organizations, FDRS and the Lipedema Foundation, mentioned above, had invited them to this conference. One of the aims of the meeting in Baltimore was to develop U.S. guidelines on lipedema. Imagine this situation in Germany or other European countries. Lipedema self-help groups organize a conference, invite self-selected physicians, and then develop a so-called guideline. Research and therapy that is independent of interests, which would be essential, especially in the case of lipedema, certainly works differently. Further, other co-signatories who do not belong to this group also have close links to the Lipedema Foundation," end quote. Then there's a little conclusion box at the bottom that says, quote, "Money makes the world go round. This also applies to patient-funded and thus controlled research into lipedema in the USA," end quote. That's pretty damning. Felicitie Daftuar has poured literal millions into lipedema research. Her foundation invited all the standard of care committee members to create their guidelines at the FDRS conference. In effect, she controls the conversation. So my question is why? Well, Felicitie is also a lipedema patient. Remember that book Dr. Herbst co-wrote with Linda Ann Kahn and a few others? Lymphedema and Lipedema Nutrition Guide? Dr. Bertsch also mentioned in his response that Felicitie Daftuar wrote the foreword to that book. I admit I have not read the book in its entirety, but I have read excerpts, including this foreword. In the foreword, Felicitie talks about her journey to getting a lipedema diagnosis, and I think her story is very telling. She says, quote, 4 weeks after giving birth to my second child, I gained 5 pounds in 5 days, including a fat pad on the inside of my knee. I felt bloated and fatigued with brain fog far worse than postpartum sleep deprivation. Looking back, I can say with confidence that my lipedema symptoms flared up due to a combination of salty seaweed soup, breastfeeding supplements, and postpartum hormones. My doctor said the fat pad was simply postpartum depression. I was not depressed and pointed out that there was no way depression could cause that fat pad, but perhaps it could work the other way around. Some physicians say, stop eating or clean up your diet to fix your legs. When we record everything we eat and go back to say, here's my proof, I only eat 800 or 1200 calories a day, some will say, well, cut back another 100 calories. That is not constructive. Women can be obese with lipedema fat and anorexic at the same time. In fact, I believe that eating too little only causes our bodies to store even more fat. End quote. I hope I don't have to tell you that her belief that eating too little causes more fat is utter nonsense. That's not how anyone's metabolism works, lipedema or not. I once again have to point to victims of starvation. But I can't even blame her for believing that because even Dr. Herbst perpetuates that myth.
So this is a study that measured the actual, or the little a, resting metabolic rate, RMR, and also compared it to predictive equations. So you go to your gym and they say, I predict this is what your resting metabolic rate is. And it turns out that women with lipedema in this study burned about 1,700 calories a day. But all the predictive equations did not predict the number of calories that you actually burn. So they predict that you need to eat less. So be careful about that when somebody calculates how many calories you should be eating. Don't undereat because your body will hold on to fat.
Oh, hey, that's that study by Dr. Shuba that I mentioned too. The one that actually disputes the idea that lipedema causes progressive weight gain. Here, Dr. Herbst is, in my opinion, twisting that data to make the exact opposite point. Interesting. I'm sorry to say that I'm very skeptical of Felicitie Daftuar's story. I find it hard to believe that her doctor told her the fat pad was simply postpartum depression. Maybe they did. There are indeed bad doctors out there, but this feels a little too far-fetched, or maybe just misinterpreted. I could see a world in which a doctor would say, I really don't see a problem here. Maybe you're imagining this because you're depressed. I wouldn't call that particularly helpful, but it would make more sense to me, but I wasn't there, so I can't say. But there is a much bigger issue. Does Felicitie Daftuar's description of her symptoms sound like any description of lipedema we've heard so far? From anyone? Bloating, fatigue, and a single fat pad on her knee? I mean, I'm not an expert, but I'm struggling to see how any doctor would match these symptoms to lipedema. I did find another article about Felicitie on the nonprofit website Giving Compass, and here's what it said about her diagnosis. Quote, after exhaustive searches on PubMed and Google Scholar and multiple consultations with healthcare providers and therapists, she received the diagnosis that would lead her to become an advocate and champion for lipedema research. Lipedema kind of found me, she said, end quote. Did lipedema find you? It feels an awful lot to me like the opposite. We've talked about differential diagnosis. It is sometimes difficult to get a proper diagnosis because a lot of conditions share symptoms. But it feels to me like some people will fight tooth and nail for a specific diagnosis, and once they have it, they stop. That could very well be the proper diagnosis, but what if it's not? What if it was the diagnosis you got 10 diagnoses ago? I'm not saying that's what happened here because I don't know, but her talk of exhaustive searches and multiple consultations is enough to give me pause. I've seen a few images and even a video of Felicitie Daftuar. She was in that Lipedema Italia webinar, shocker, I'm sure, and she looks to me like a very average-sized lady. If she really believes that lipedema is a progressive condition, how did she prevent that herself? Well, she has indeed answered that question on her own Lipedema Foundation website. Quote, Felicitie had lipedema symptoms occur at 4 weeks postpartum after her second child was born, and has successfully managed the lipedema symptoms through only nutritious eating, exercise, caffeine, and natural hormone fluctuations. She credits nutritious eating, Pilates, and her 3 girls with keeping the lipedema fatigue in check, end quote. Oh, so basically none of the treatments promoted so hard by everyone in this community? No MLD, no pump, no liposuction? That's so strange. Well, if everyone just ate a nutritious diet, exercised, drank coffee, and had natural hormone fluctuations, whatever that means, then no one would even need MLD and liposuction. We should just promote those other things instead, right? No? Huh. I'm like hardcore conspiracy theorizing here, more than I have been. But is it possible that the Lipedema Foundation is getting some kind of benefit from promoting MLD and liposuction? I won't lie, I do feel like an absolute scuzzball calling this woman's diagnosis into question. I do genuinely believe she was struggling with something that needed real treatment. And I believe her doctor very well could have been dismissive towards her. But do I really believe she has lipedema? In my opinion, her own description doesn't match any description I've ever seen from anyone in this community. Despite the possible issues I see with Felicitie Daftuar's Lipedema Foundation and the FDRS, I do believe multiple things can be true at once. She could genuinely believe she has lipedema and genuinely believe her work helps people, but she could also be steering people horribly wrong, either by mistake or not. I think the same could be said for people like Dr. Herbst. When I described her as caring and compassionate, I meant it. In my own personal opinion, I think it's very possible for people, even scientists and doctors, to kind of stretch the truth a little in the interest of trying to help people. Okay, maybe the edema theory isn't proven, but a lot of people feel better after MLD, so maybe we can come up with a hypothesis that kind of explains how there could be edema even if we can't prove it. Okay, maybe there aren't a lot of good studies on the effectiveness of liposuction, but again, it makes a lot of people feel better. How can we explain that? Okay, a lot of these patients claim they gain weight while starving. How can we explain that? I also want to point out that nearly all of the experts in Dr. Herbst's sphere heavily promote healthy habits that I think we can all agree on. Exercise, nutrition, maybe those are the real focus and all the extra stuff is just kind of added on to make people feel like they're really doing something to treat this illness. We can't forget the placebo effect is extremely powerful, but it's hard for me to think that's the real motive when I consider all the different companies and practices Dr. Herbst and others are involved with, especially liposuction. Maybe I'm just a hopeless optimist, but it honestly shocks me when someone who seems nice and helpful turns out to be dubious. It's hard for me to believe. It's like it splits my brain in half. I felt like the scum of the earth for insinuating that Dr. Herbst and some of her colleagues could have ulterior motives. But finding out Dr. Bertsch agrees and had even more evidence of that made me feel validated. And also horrible. I like doctors and scientists. I generally advise trusting them. I don't want to believe that some of them could be constructing a ruse for financial benefit. Possibly. I don't want to believe that potentially thousands or even millions of people are being misled by supposed experts. But if that's true, then they could be suffering more than they even realize.
Chapter 16, The Lipedema Ladies.
We absolutely cannot talk about the lipedema controversy without talking about the people most affected, the patients. I know this is coming very late in the video, and that's because I needed you to see, really see, what these patients are facing. Based on what I've seen during my research, a large percentage of lipedema patients start seeking a diagnosis not necessarily because of pain or discomfort, but because of weight gain. Pain is a very common secondary symptom, but so many of the testimonials I've seen begin with, my legs have always been bigger than other girls, or I started gaining weight and I didn't know why.
I think, oh my God, look at those ankles. I always wanted that and my legs were just straight.
You know, I would say I weigh and I measure my food, and I do that without exception. And I write it down. Here's a log, and they wouldn't believe me.
The running theme with a lot of these patients is, I'm different, I'm bigger. So what's wrong with me? When something feels so fundamentally amiss, what could be more devastating than going to the doctor and hearing, you're fine, there's nothing wrong with you. Or worse, you just need to lose weight. For a lot of these patients, being told there's another explanation is a huge relief.
People look at me and they're like, just lose weight. And it's not that simple, and it's not my fault.
I'm not the loser that I thought I was,
heaviness than now.
This experience is very common for a lot of people in the lipedema community, so much so that it kind of unites them in solidarity. I use the term lipedema community because there is a strong connection between a lot of patients. Some groups call themselves lipedema ladies or lippy ladies or even lipedema warriors. This diagnosis, and often the struggle to get the diagnosis, effectively becomes part of their identity. In a lot of ways, I admire that. This community is so passionate and supportive and positive. The amount of patient-led organizations and support groups is staggering considering how few people even know about this disorder. I've learned a lot about these women from watching their videos and listening to their podcasts, and I can't help but feel for them. No matter what you believe or don't believe about lipedema, there's no denying these women are suffering and they're trying their best to cope and uplift others in the process. But as much as I admire some parts of this community, there are other parts that are much darker. There is such a push to accept people with lipohypertrophy as lipedema patients, people with larger limbs and no pain. And this isn't a problem exclusive to obese people. Even people who are a healthy weight get caught up in this. If your legs are only slightly larger than average, maybe you just have stage 1 and it hasn't progressed yet. What a relief. Now go get liposuction before it gets any worse.
At the ISL Congress in Buenos Aires 1.5 years ago, I saw pictures like these at the Congress, at the Lymphology World Congress in Buenos Aires. This is a woman, she was diagnosed with lipedema and she received liposuction.
It's bizarre to me because a lot of these groups perpetuate body positivity and body acceptance. But I just wonder how many people have gotten absorbed into these groups unnecessarily, just because someone told them their body shape was unusual. People who have a larger lower body are being told, often by people online, that they look like they have lipedema. And I'm not just speculating about that. I've seen it happen to people online.
A nurse reached out to me, someone who worked in the charitable arm of an organization that researches lipedema reached out to me. Basically, I had a lot of professionals in the area of studying lipedema reach out to me and tell me that I have this condition.
Fast forward to 2019, I thought I'd finally made peace with my body. And then the pandemic happened. I downloaded TikTok and I had so many people leaving me comments, sending me DMs. I think you have lipedema.
And I'm sorry, but you simply cannot tell that someone has lipedema just by a cursory glance of their body. But that's so common in this community. I've heard plenty of people talk about how they see it everywhere and even ask how to bring it up to those people they suspect of having it. Another prominent patient in this community is Siobhan Huggins, and she tells a similar story.
It was the second picture, the after picture, where 3 different women with lipedema reached out to me privately. They reached out to me privately and said, there's some things in this picture that lead us to believe you may want to look into this. My trick is that I have cards that say, like, do you have a patient that looks like this, or does this look like your legs? And I'll give them to people.
And that's especially concerning because it seems to happen sometimes to people who don't even have other symptoms.
So I didn't have pain to begin with, but then I started feeling pain. So I started researching more. I found such an incredible community and started to really accept and understand the fact that I have this chronic progressive disease. And no matter how hard I diet and exercise, those areas with the diseased fat are not going to change.
It's cases like these that make me even more convinced that Dr. Bertsch could be right about people suffering with psychosomatic symptoms. He points to external beauty standards, and I think that's sometimes the case, but I would also argue if someone feels dissatisfied with their legs, goes online, and discovers this illness called lipedema that often causes pain, that might contribute to their own feelings of pain too. But I can't blame support groups for everything they believe. A lot of support groups I've watched were sponsored by LymphaPress. When I first found out LymphaPress hosted these patient groups, I thought it was nice. Sure, this was a corporation, but I thought it was generous of them to dedicate time and space to patients. But with what I know now, it just feels Kinda slimy. Usually these roundtables feature a handful of patients, often influencers, and occasionally specialists as well. Dr. Herbst and Linda Ann Kahn often show up for these roundtables, and people get so excited you'd think they were the second coming of Christ.
Literally adore you. You're one of the superheroes. You're somebody who I can't wait to meet one day.
Oh my goodness, that's gracious. Wow. Very humble. Thank you so much.
These patient roundtables and also interviews Brenda Viola has held with other various patients are some of the biggest sources of sketchy information and wild speculation that you'll find within the community.
There were points in my life where I was down to 600 calories and I was still gaining weight. I was able to lose over 6 dress sizes, and I got down to a size 10 by eliminating my food intolerances.
Wow. So where do you get a food intolerance test? Do you go to your doctor and ask for one, a general practitioner? Yep. How do you do this? Can you buy one online?
Yep. So you can try to look for a practitioner. A lot of naturopaths do a test like that.
I have the type of lipedema that affects my upper and my lower body. I said, oh, okay, well, let's see what I can do, because I have it in my breast, my upper stomach, my pannus, my flanks. I said they make pumps for this area. She said,
I love that you asked that question, because maybe there are some women watching this right now and saying, they make pumps for this area? Yes.
And of course, Brenda Viola, Dr. Herbst, and Linda Ann are all there encouraging all of that. I called the US lipedema research field an echo chamber earlier, but I'd argue it's even worse within some of these support groups. And companies like LymphaPress and the experts on these calls just perpetuate that even further. It's honestly kind of frightening, but I'm sorry to say this is not the first time I've come across something like this. My interest in alternative medicine and pseudoscience has introduced me to all sorts of communities like these. People suffering, truly suffering, but maybe a little misguided on what they're actually suffering with. Doctors don't know how to help them, and so these patients end up forming their own groups and sharing spreadsheets of doctors and other kind of practitioners who will help them. Unfortunately, those lists of practitioners are often full of alt-med people, hawking all sorts of unproven, untested treatments. Maybe because they think those treatments help, or maybe because they recognize an easy mark when they see one. Vulnerable, suffering people who've not been helped by modern medicine and are desperate to try anything. I would recommend the Netflix miniseries Afflicted if you want to see examples of what I mean. In the case of these lipedema patients, though, it's more complicated than a factitious disorder because quite a lot of them probably do have lipedema. The diagnostic criteria of lipohypertrophy and fat tissue pain are a pretty wide net in the grand scheme of things, but for many of them, I would argue that their more urgent problem is the stigmatized and misunderstood condition of obesity. Obesity isn't just laziness or lack of willpower. It's a complicated mess of physical and mental issues that can take a lot of effort to overcome. I say that as someone who has lost a lot of weight but still struggles with making the right choices. It's hard, and so many people shame and blame people who are obese, including doctors. The way we as a society deal with obesity leaves much to be desired. It's hard to even find therapy for food issues sometimes. I wish we in the US had more resources and care for people suffering with obesity, but we have a for-profit healthcare system that harms everyone, patients and doctors and everyone else in the system. People truly struggling just get sent away with vague prescriptions of lose weight. So when some of these people go online and find this explanation, a disease that makes you gain weight through no fault of your own, it comes as a relief. And then this idea gets perpetuated in the media. You have real medical doctors spreading this message. You have a foundation funding research that repeats this message. You're not fat, you just have lipedema. And to top it all off, the people repeating that message are also compassionate and personable. They commune with you on webinars and podcasts. They demonize the people who say they're wrong, calling them medical gaslighters, fatphobes, and misogynists. But most importantly, they fight to get you treatments those other doctors don't want you to have. I'm obviously not speaking about every lipedema patient. I can personally attest that many people with lipedema have been in my comments refuting a lot of the misinformation we've seen from Anna and Dr. Amron. But unfortunately, misinformation is a huge, pervasive problem within some of these communities, especially in the US. And I don't know how to break through that. I don't know how except to present the evidence as I see it. This video started out as, I thought, an interesting deep dive into some academic disagreement. I wasn't expecting to find all this stuff, and I feel terrible. It feels terrible to have to say to people who are suffering, I think you might be getting lied to by people just trying to make money. I don't know what to do now. Whenever I come across something bad in the world, I feel like I should throw money at it. And that's a good thing to do, but how do you do that when so much of this field has been infiltrated by all of that? I want to do something. I feel like I want to give you a call to action, but I don't have one. I'm also bummed by a lot of this because it reveals a huge blind spot we have in the scientific community. It's unbelievable to me how something like this could happen and nearly completely fly under the radar, because we as a society need to be able to believe experts. We as individual human beings do not have the capacity to be an expert and dig into the research on every single little thing. It's already difficult enough to weed through the charlatan pseudoscience practitioners. What are we supposed to do when we can't even trust our legitimate scientists? One thing I don't want is for anyone to take this information and go harassing any of the people I've talked about. That doesn't help anyone. I think a better course of action is to point people towards the clinicians who do follow real scientific evidence, as difficult as that is to parse nowadays. And of course, I want to thank the ILA and specifically Dr. Bertsch for the work that they do. I would have never realized how deep the problems were in the United States without them. I don't think anyone has all the answers here, but I think they're trying their best. I think of all the voices, they're the ones closest to the truth, at least closest to real science. The problem is that their views are getting absolutely annihilated and buried, especially in the United States, where I feel the problem is the worst, and probably because this is where it's the worst. And if you made it this far, thank you. Once I started uncovering these things, I felt like I had to use the small platform I have to say something. I'm sorry this video turned out to be so sad. I hope you got something out of it, or you can share it with somebody who might get something out of it. There's so much more I'd like to discuss in future videos, so stay tuned for that. But I've taken up far too much of your time already. I hope to see you again soon.